This meeting to order. Would like today's date, November 19th, the meeting of the Board of Directors of the Palo Verde Health District. Will you please stand for the Pledge of Allegiance? I pledge allegiance to the flag of the United States of America. Joanna, can you please take motion?
I would like to announce. Director Starting will be participating remotely pursuant to the just cause provisions of the Brown Act in connection with a physical or mental disability as provided by the law. This provision is different from the traditional remote participation requirements. Director Starting is there an individual 18 years of age or older present in the room at the remote location with you? And if so, what is the general nature of your relationship with such individual? Ms. Sarden?
You're muted, Ms. Sarden. You just need to hit the microphone button at the top right of the screen.
I apologize. There's no one here. I'm alone.
Thank you.
You're welcome.
Carmela Garnica?
Here.
Rosa Rowell? Here. Sarah Katrina Sarden?
Present.
Director Dr. David Brooks? Director Sandra Hudson? Thank you.
Okay, public comment. This is an opportunity for citizens to speak only on items listed on the agenda. For the record, please state your name. The board has a policy of limiting any speakers to not more than 3 minutes. Public input may be offered on the agenda item when they come up for discussion or action.
Tonight is going to be, you hear me? There's four presentations on the agenda for services from Palo Verde Hospital. The agenda said to unsolicited presentations. I came to my attention back in July of this year that this denied made a phone call, and unfortunately, I'd say she was in a meeting and she dialed somebody accidentally, loud as you would call it, and it was in tune to a meeting. Dr. Bo and Mr. Alex, and they're discussing in detail the contract it would take in order for them to purchase Palo Verde Hospital. Ms. Anaya was asked at least a couple of times, I know once by Mr. Director Hudson, she engaged in meeting conversations reference to the sale of the hospital or services of. She said, I believe she said there was some looky-loos, but nothing serious. I have a transcription of that call. It's pretty much everything that's on that other presentation today. And for the other ones attending, we're going to give a presentation that appears that this conversation started 5 months ago with the gentleman I listed. So that would be, I don't know where you're starting. So I don't know if the board is aware of this or approved it, but that is what occurred. And I have that transcription and recording. Therefore, if your council would want it. Thank you.
I can respond to that. Dr. Bo was unsolicited. Dr. Bo approached the hospital by virtue of Senator Alex Padilla's office. They informed me that they asked Dr. Bo to take a look and see if he had any idea, how to help. And so at this time today, we'll talk about how the presentation section came to be, but we'll get to there when it's done.
Thank you. Is there any more public comment?
Good evening. And according to the recording, that's all I've asked Sandy, and I am several times as she's spoken to any of the physicians and whether or not she would have named. She blatantly said no. Excuse me for being in a hurry. I worked 8 days in a row. Today I stand here before you all yet again. We have begged for resignations for both board and Sandra. The response is deafening. But today I bring forth addition and notification to both the board and public the absolute lack of integrity and morality Sandra and Maya continues to display on a regular basis. The board fails their due diligence to evaluate her performance and take action. It's your job. Sandy, you have Lady Lion on your tag. I used to think that was a description of a great leader. However, great leaders and mentors embody a set of traits you lack: integrity, gratitude, humility, the ability to seek advice from counsel and constituents. But every week, if not daily, I hear of yet another disturbing crisis you create. Your greed and nepotism outweighs the benefit provided to this community, even at times placing patients at risk, placing priority and integrity below your own agenda. You know what I'm referring to, including staff. Great leaders do not demand respect. It is something earned through consistent words backed by action. If all your employees are leading secondary to your leadership, you then should stop and self-evaluate where you are failing with your performance. This past year of discovery, we have been shown where your failures are. I encourage the public to tour the hospital. It is a direct reflection of your failures. PVH is a skeleton of death of what was or could have been. You lack integrity or morality, willing to cock your nose in spite of your face. Here's your performance evaluation, and you've lost revenue, billings behind over 3 years, wasted monies on lawsuits. No department budgets, no management, no department leadership or collaboration, unpaid PTOs, laid off employees, allowing staff to show up intoxicated. Locking employees out once you receive their resignations. Hiring several employees who have quit without notice numerous times. You attend beta conferences on the community's dime, which are evolutionary and staff development, culture of safety, teaching, and you implement none of it. Even falling asleep with a hoodie over your face. Great leaders get employee buy-in when they are heard and validated. Patient outcomes increase, call-outs decrease, and direct mental health of your staff flourishes. How many are on medical leave due to stress at the hospital? How many show up unsure of job security or how they will pay their bills? Daycare, where will they work if you close? All while you sit pretty with all your housing and utilities paid. Your CEO gets $30,000 bonus for what? Where is she? Oh,
Okay.
on leave.
Thank you very much. Any more public comment?
I'll give my time.
We don't yield.
You did it formality, and I'm going.
We don't yield.
The board has decided to rob, cheat, and steal from this community, leaving those that live.
We don't yield anymore. Any more public comment?
Yes, they do.
Great leaders get employee buy-in when they are heard and validated. Patient outcomes increase, call-outs decrease, and all mental health of your staff and founders, I think. How many are on model leave due to stress? How many show up unsure of job security or how they will be paid their bills and daycare? Where will they work and when you will close? All the while you sit pretty with all your housing and your utilities paid. Your crew gets 30,000 bonus for what? Where is she? Oh, medical leave. The board has allowed me to rob, cheat, and steal from this community, leaving those that live here back up. And the pieces of their hospital closes while you go back to your plush house in Whittier. You have bullied and brutalized your way through this community, leaving a trail of destruction. You have never humbled yourself or owned your failures, nor have you earned what you have stolen from this community. You have shown me what kind of a leader I refuse to be. We again are asking for you to resign. The recall will happen, and the first thing on the agenda is a new leader.
Any more public comment?
Dr. Sullivan. First, I want to address what Johnny Rodriguez, our city council member, said. And I add to that, Mr. Rodriguez, I am informed and I have the knowledge of your negotiation with another one of these people that you are claiming to be unsolicited, come up here, and you guys solicited that. And I have evidence for it. I'll bring it up at court if it's needed. Number two is the lack of brain behind any function you do, which is unbelievable. You delegated all your authorities to the attorney, and the attorney is taking it down with making thousands of dollars. If you go to item 7E, it's so ridiculous. You have an item in there for board approval that says square to direct staff to, and in front of it is blank. To do what? To write you another $67,000 check, Carmelo? That's what you want? You want a new van? Is that what you're looking for? Why is that open-ended agenda? And then you violate every part of Brown Act, every part of Robert's Rules of Order, or Rosenberg's Rules of Order, which you have no clue what it is. I know that. I don't believe you're smart enough to know that. But you violate every part of that. Every day, every time you have a board meeting, you violate that. Case in point, you violate your own bylaw. Have you read your bylaw, Carmelo? Yes? No? Recently, in the last 1 year, have you read it? This blank face tells it all. Special meeting. This is a special meeting, Carmelo. A special meeting may be called at any time by the president or by 3 board members by delivering written notice to each board member. Dr. Brooks, did you get a notice of this board meeting?
Today.
Oh, today. Now I'll read it. By at least 24 hours prior to the time of such meeting, you violated your own bylaw. Rosie, did you get a notice of this meeting?
Yes, I did.
When did you get that?
Yesterday.
What time? About.
When I opened up my email address,
Okay.
it was there in the morning.
I opened up the same email. It was 4:31. So it was less than 24 hours. Sandy Hudson, did you receive a notice? Okay. It's self-serving agenda, Carmelo, you have. You've never cared about this community. You cared about you and you only. And if you think by becoming a board chair, by selling the community, you did anything, you just put a negative mark. This hospital is going to close. On your own.
Can you turn it up? Anybody else have a comment? Seeing none. Is there any board comment? Dr. Brooks, do you have any board comment? Tina Sarton, do you have any board comment?
No, not at this time. Thank you.
Ms. Hudson, do you have any board comments?
Ms. Garnica? Can you hear me?
Yes, we can hear you.
Well, what I would like to say first of all is I've asked Sandra and I at 3 occasions as she negotiated for the sale, the lease, or disposition of the hospital in Big Bend, and she told me no. One of the ladies there has a copy of a transcribed tape. I'm sorry? One of the ladies there had, one of the women there had transcribed a copy of the tape and written about this on Dr. Vogt, where they were negotiating on hospital back in July. I find that probably inappropriate. And I also am really disturbed by the fact you are hiring back and putting on this someone who showed up to intoxicated without having the tip. I really think you need to tweak your program and watch out for this because you're fortunate someone I care is right.
Ms. Hudson, you're breaking up a bit, just so you know, perhaps, I'm not sure if you're in a wrong room or it's not.
Well, I don't really have a lot of options here, but I can try again. What I would like the public to do is listen to the tape of Sandra and I and Dr. Bo and make their own opinion. So if you would grant me the time to have it played, I'd love that.
However you want.
Yeah. I mean, that's a board comment.
Well, you need to tell.
I have transcripts copy there. They're going to be passed around.
So what do you
But I
want to do?
would like people to listen to Sandra in her own voice, what she is saying. I think the community is owed that.
How long is it? It's not on the agenda. However, how long is it? And we can, but this is a heavy agenda, but
It's board comments.
So that-
Dr. Slowly, I'm speaking with Ms. Hudson. Ms. Hudson?
Yes,
Okay, how long is it?
I haven't timed it. I don't recall exactly. They'll hand you a transcribed copy of it and you're welcome to listen to it. And if you feel like it gets too long, do what you need to do.
Well, do you think the transcribed copy is sufficient if it's being handed out?
I don't think it's effective as hearing her say what she says about the board and the community.
41 minutes long.
Okay, I did 20 minutes and we will provide it, okay, her comments are, but it's up to you. You're the,
No, that's too long. We got a long agenda. We got a big agenda. But we have a.
I think the country should also have a big problem if she's negotiating without being authorized to.
We have the transcript, you said, right? Okay. I think the transcript would suffice. So is that,
Put the transcribed copy into the record. That would be a good start.
thank you.
okay, Ms. Rosie Rowell, do you have any public comment? Thank you.
Ladies and gentlemen, I have an announcement to make. I very much regret today that I have submitted my resignation to Ms. Garnica as a member of the Palo Verde Board effective November 30th. It has been a real pleasure to spend these 6 years with Carmela and the other board members working to help our little hospital. However, I do have family concerns that I have to attend to, and my family unfortunately has to come first with the hospital coming in a very, very second. And I hope that as I leave, I will be able to help the hospital in other ways. I would also hope that the tenor of anger and accusations, real or not, will calm down so that we could all come together and help this hospital recover and become the wonderful little hospital that this community deserves. And I think tonight is going to be the beginning of help that to come our way to help this hospital. That's what I'm praying for. That's what I want for this community, for the hospital employees. We have wonderful, wonderful hospital employees. They have sacrificed. They have taken on other agendas in their work, so that as we have employees who have left, they've taken on their jobs as well. So they have sacrificed and they have worked hard. And I hope that everybody would understand that the employees that are left there are working very, very hard. And Ms. Anaya, as far as Ms. Anaya is concerned, she has been here over 12 years, which is longer than any other CEO has been here. The other CEOs have come in, grabbed the money and left 1 or 2, 3 years later. She's been here 12 years. She has gotten this hospital acute access. She has gotten grants and money and worked very, very hard. And she has a house that the other CEOs have worked, have lived in, it's no different. And she's been paid less than they have. But they did very little, and she's done a lot. And I have nothing but respect and admiration for her and affection for her, as I do for this community. Please, let's come together and help this hospital succeed. I think that this is going to be a good night to start.
It is. I don't know.
Anthony.
Somebody should do something on it.
I have nothing to add. To say, so, next item is there a motion to approve the agenda?
So I think-
I need a motion. Okay. I have a second. Yeah, we'll do a second. Can we call for the question?
Vice President Rowell,
I,
Director Sardi. You're muted, Director Sardi.
Aye.
Director Brooks.
Aye.
Director Hudson. President Garnica.
Aye. Okay, next item on the agenda is, reports. Update on operations and finances of the district, so I have a statement. Good evening, everyone. Before we begin addressing tonight's agenda, I want to provide a brief general update on a couple of items. We continue to work closely with all current and prospective partners to find solutions to each of the challenges facing us and every rural hospital in California. The top priority is securing substantial external funding to continue patient services and stabilize our financial condition for the future. The good news is that we have recently had productive, very encouraging discussions based on the funding request we initiated several months ago. We thank the leadership team of the U.S. Senators, Sheriff and Padilla, Congressman Reese, and Supervisor Perez, Assemblyman Gonzalez, and Riverside County Executive Officer Jeff Van Wagner for their continued support. While the details will be provided later, the district is pursuing temporary state and or county funding that would allow us to fund the intergovernmental transfer program. This step is critical as it would bring in considerable Medi-Cal reimbursement revenue. We are making every effort to secure this funding promptly. Thank you for your patience, engagement, and partnership. With that, let's move on to our agenda. This will be a standing agenda item, an effort to keep the public informed of new developments regarding the current financial condition of the district and operations of the hospital. Are there any questions from the board? Tina, do you have any questions or?
No, I don't have any at this time. Thank you.
Ms. Hudson?
No.
And then B. Did I skip a?
Public comment.
Oh, I'm sorry. Public comment, is there any public comment? Seeing none. Oh, Dr. Sullivan.
You discussed a lot about the financial of the hospital, but you've never, in the last 2 years that I've told you what you did wrong, you've never done anything to correct what you've done wrong. You have done nothing to increase the income of the hospital. You have not made any effort to discuss with doctors in this hospital what you can do to increase the income of the hospital. You have not gone to the doctors in this hospital and asked them if they would take 10%, 20%, 30% so you could decrease the expense of the hospital. And these are all on you because you want to be the board chair. You did everything, you kissed Trina's ass so could be board chair. But now you have a hospital that's in bankruptcy and you've done nothing. You paid Trina $200,000 last year. So she would be our COO and CNO. She has been out for 3, 4, 5 months. The hospital seems to be doing better. So was that just to hire her, give her $200,000 so she could vote for you to become board chair? Is that all you cared about? Where does the community fit in your agenda, Carmelo? I understand that Rosie has enough ethics to resign under pressure by whatever family, community, but where is your ethics to resign? Everybody has told you that what you've done is wrong. It has nothing to do with personal agenda. I'm more friend with your family than anybody else in this room. But they still call on you to resign because if the hospital finances is down, it's because of lack of oversight, spending all your money on this attorney sitting here and not knowing what to do for this community and this hospital. So please resign.
Any more public comment? Okay, seeing none. Item B, medical executive committee report.
We had, well, let me get you through itemized. We had no management report, no committee report, no old business. We had an MEC meeting just before the meeting today, under new business, and none of the members of the MEC have been approached by this board, administration, attorney, or otherwise to have any input in any of the prospect people on item 6, A, B, C, or D, purchase of the hospital, or interventional care, or operation of the hospital, none. And in fact, Dr. Rafato, who is the Rural Centric Care Organization, he came here and he had discussion with you guys a few months back, almost a year ago, and I don't know what happened to that. I don't know if you guys, for whatever reason, didn't like him, didn't agree with him, and you sent him on his way, and then now all of a sudden you solicited help from him. I don't know what these issues are, but MEC, none of the MEC members were notified of this. Because of that, MEC voted no confidence to the board for taking any action on this agenda without the input from MEC. Even having a presentation would be an item, an action. Nobody consulted us. The second thing was Dr. Bowman has given me authorization to discuss his case in public today, and the medical staff approved his credential recommended to the board months ago, and the board failed to take any action. Then the board brought it back again, and the board failed to take any action. And today, I don't see it on the board closed session agenda. Well, he filed a lawsuit against the hospital. That's how you guys are losing money. Unforced error. You're shooting yourself in the foot. You get rid of radiology tech because Trina didn't like him. Then Trina doesn't show up. You bring the radiology tech back. You get rid of radiology because Trina doesn't like him. Then you bring the radiology back again. These are all lawsuits that you did not need to do. So as a result of all that discussion, again, as I said, vote of no confidence to any action the board takes as far as it's changing the management from Sandy and I to anybody else. The best management you can take is to resign. That's what we recommended and that's what we demand. Under 5, there was no credentialing interview, and under 6A, B, C, and D, we have practitioner 5058, 5066, 5067, and 5070 for initial appointment, which was recommended. Practitioner number 315150 is recommended for reappointment. And this is the physician that you decided you didn't want to hear the medical staff opinion last time. I hope he is not practicing without privilege. That concludes my report, unless the board has any question from me. I have nothing to add.
Okay, thank you. Is there any question from the board? No, board? Dr. Brooks, Rosie, Ms. Hudson,
Yeah,
Ms. Sardi?
Yeah, I just have a couple of comments regarding Dr. Bowen. It's not personal. Dr. Slobey, you know, and I cannot discuss it openly, and you're aware of that. That's all I have to say about that.
It's
The other
personal,
thing
I
is,
know.
you're
It's
off on
personal.
my salary. I make $160,000. That's for public record. There's nurses that make more money than I do in the hospital. So you're incorrect. There's a lot of incorrect things being said, with all due respect.
$50,000
Thank you.
bonus
That's
at
all I have to
160,
say.
that means
Thank you so much.
600,000.
Thank you. That's not true.
Yes.
Not
Okay,
true.
So we kind of gone.
It's false. It's public record. Pull it.
I'll bring it next time.
Yes, please do. It's false.
Does that conclude your comment, Ms. Sardi?
I'm sorry.
Does that conclude your comment?
Yeah, I mean,
Okay.
just there's a lot of things being said that's so inaccurate and wrong with the other agendas in place, but I'm not gonna go there. Thank you for your time.
Okay, any, public comment on what Dr. Salome spoke on? No public comment. Okay, public comment is closed. So next item on the agenda, we have open stations, item 6. Advancing interventional care in life. Oh,
Second.
okay.
Good evening. There are 4 proposal presentations from interested parties for your consideration. These interested parties approach the hospital with potential solutions and services. This is the extent of what we have received thus far. However, there are other interested parties that have contacted the hospital. As more information becomes available, these will be brought to the board for review. The presentation should last between about 15 to 20 minutes each, and we will ask that all questions be held until after all presentations are completed. The board can direct staff to evaluate the office's viability for continued operations, formally recommend to staff to seek additional proposals in a more formalized process, or have staff evaluate the proposals presented today as part of the pendency plan budget to be presented to the bankruptcy court. Now, Ms. Gonzalez will introduce each of the presenters who will be speaking tonight.
Mr. Rose. So our first presentation this afternoon is going to be the Advancing Interventional Care in Blythe, California by Rural Medical Partners, Las Vegas, Nevada, Dr. Edward Callahan III. Doctor, are you with us?
I am, yeah. Thank you for the introduction. Yeah, I'm happy to discuss with you guys a little bit about what we do and kind of the plan that I would recommend implementing there in Palo Verde to add some additional services. So a little background for us. We are a group that brings specialty care into rural hospitals, typically critical access hospitals, especially in the Mountain West area. We begin usually by the beauty of our program, we add multiple specialties, not only from medical, clinical side, but also through an interventional component. And I think that's both needed in what we're doing here. And so we can just roll through, I guess, a little bit of what we do from this slide deck here. So let's keep going down. But yeah, just to do a high level intro of what we typically do, we bring in with an APP driven model there locally, which you already have through your rural health clinic. We expound upon that with other interventional subspecialties to bring cases in that are elective in nature and primarily done in an ASC type of setting, a surgery center setting in most urban communities. We do that by being able to bring in those specialists to do the cases as needed. And so we entered in a revenue share model with the hospital, which is, again, a shared risk model, which is very unique. We don't take a flat rate, unlike other competitors in the market that would need a cath lab staff. We bring our entire staff with you. And so because of that, like I mentioned in this slide here, we provide that turnkey management operations and staffing for a lot of these specialties. In addition, we have another aspect of our company that is involved in turning around from a facility, really augmenting what's currently in place in your medical specialties through your PCPs, other, whatever family practice or APPs you have locally, to augment them with specialty care. As I'm sure you guys know, Blythe does not have a lot of specialty options for medically, whether that be rheumatology, oncology, neurology, et cetera. With what we do, we bring those in to augment and provide further support for your current primary care physicians. Yeah, I guess we can go through some of this too, that typically your current environment right now, you're sending all your cases out that could do elective cases to Palm Springs and or El Centro for most of your interventional cases. So the ones that could be done locally, the ones that we would ideally like to capture and provide for not only just patient care, but this is a significant revenue driver, as many of you may already know. Interventional cardiology, peripheral vascular disease, IR are the main revenue drivers in any facility, whether that be Kaiser, whether it be all the way down to critical access hospital. And so being able to capture at least those that are elective and able to be done safely. And like I said, our group, we cap ourselves at those that would only be done in a surgery center setting rather than those that could be done, even though you are a hospital outpatient facility. So we can keep going down with this slide deck if you'd like. Talk a little bit more. Yeah, so there have been studies that have shown what could be done in some of these local environments and how few patients actually go. There's when the distance is at least 2 hours or more, fewer than 25% of patients actually go to get their care from, even though they've been referred. So our goal is to provide a lot more of that. The issue with most rural hospitals, especially critical access hospitals who are barely operating in the black, they usually can't afford to even recruit or retain these sort of specialized staff for a cath lab or even some of these more specialized surgery cases that we were able to bring in. You also can't justify that for 2 to 4 days a month for interventions. And that's probably what Blythe would see, probably 4 to 5 days a month of interventional cases. And as you can imagine, even further along that, the proficiency for your staff is incredibly low if they're only doing that sort of volume per year. So this is why even bringing this in, your typical cardiology program, for example, is about 2.5 million a year with staff. We're able to bring that up as needed, offering a really unique solution to critical access hospitals. So we can go to the next slide. Yeah, so problem here, you'll see a lot of specialty groups, especially, I don't think you guys have it specifically, but a lot of times the larger facility will offer clinic, hoping to recruit some of those patients to come and see them for the intervention because that's where most of the reimbursement occurs. That's pretty common. You'll see usually you're only scratching the surface because it's not their goal to build a service line there at your community. Their goal is to build theirs back at the mothership. And that's what's unique about our model, where we do a shared risk model and really do ultimately a revenue sharing of collected reimbursement. Our interests are aligned. We want to do as many cases as medically safe and necessary and feasible to do in your facility. And we also share in the cost of building a sustainable program by building out the clinic aspect of this as well, with an APP, usually a nurse practitioner, bring in the echo tech or other diagnostic techs that are needed, and also an office manager or a clinic service line director to really drive this and create this into a long-standing program. So we can go to the next slide. Yeah, so this is our business model. We work with the hospital to create that clinic. We pay for a portion of that staff to make sure, especially from an early stage, to bring this. Most hospitals struggle to add in an extra FTE for an APP of any type. We also bring all the personnel required for all the procedures, and we utilize one of the current ORs. We travel in as needed to do those, so we plan these out. We have prior auths on these prior to coming in for these cases, and then we accomplish as needed. The only thing the hospital is responsible would be for the purchase of whatever equipment, which is usually minimal, but this is roughly about $600,000 to do this. So we'll get to that on kind of the overall plan on rollout of this, and I think it has to be a phased approach with the current financial status of the hospital. But our goal is to really build this specialty growth in the community. Obviously keeping the patients there locally, not only better for patient care, but also obviously financially too. You're not sending millions of dollars out to a facility where they get referred for the cases to be done. Go to the next slide. Yeah, so our offer programs, so typically we start from an interventional standpoint with interventional cardiology, peripheral vascular disease, electrophysiology, and ultimately we'll add in IR to these as well. We can add any other interventional specialty because it's the same sort of equipment, same sort of staffing. Even if you needed other surgical specialties too, we were able to bring that in as well if needed. You go to the next slide. Yeah, so three different pillars to our model to really support rural hospitals. Number one, like we've been talking about, is the interventional component of this. I mentioned briefly the specialty clinic and especially the doc-to-doc sort of consults to really augment whatever you're doing. If you can imagine, if you're beginning to add neurology, telehealth visits, and/or support, there's going to be a lot of follow-up imaging, for example, that comes from that. We recognize that with additional FTEs and additional clinic visits that need follow-up that may surpass what the current facility has in place. We think through that too by being able to bring in an extra internal medicine physician if needed, or further support with whatever is currently there locally. Do we need to help assist with making an additional hire? We're involved at all those sort of aspects because, again, our goal is how can we create a sustainable clinic and future for these specialties there at that local facility. And then the third pillar of this, and where I view this as actually phase one with Palo Verde, is to get involved on the business development strategic growth side with both 340B optimization. You guys are already a critical access hospital and have an RHC, which are massive programs in and of themselves. There's a lot of optimization that can be done with getting a 340B, both with the pharmaceutical side of this, which is largely driven from that middle pillar, the specialty clinic. There's the beauty of this program, which is a government program that really helps critical access hospitals, allows these facilities to take advantage of the pharmacy aspect of these two. As you can imagine, there are many drugs that come from specialty clinic, chronic patients, even interventional patients. Those are able to be captured and drive additional revenue to the hospital and on the realm of at least somewhere between the 8 to 15 million a year sort of aspect just from that alone, besides the interventional component. So as I look at this in a phased approach, which I've written out a proposal of how I would envision this being implemented. There are components that we do with business development too, in terms of chronic care management, which is CCM, if any of you have heard of that, which is really just following a patient and getting paid for the follow-up that most clinics already do, calling a patient, following up with labs, looking at the chart. That can be implemented with zero capital outlay. The same with 340B optimization. Our group partners and is able to create this whole optimization and planning without any capital being committed. I envision that starting as phase one. Phase two would be where we're adding an additional specialty to augment your current RHC, not adding FTEs unless needed, but begin to drive revenue between the pillar on the far right and then the middle pillar. And then third phase would be, once there is revenue generated, to begin thinking about adding interventional cases, even the most basic ones in the beginning that don't need significant upgrade in capital equipment, to begin there. And that includes interventional pain, for example, which could be done today there, or augment what is currently done there with your CRNAs, and then continue to add into what other interventions. So that's how I would envision a rollout of these services that could start generating revenue within the next few months without any capital outlay, and then going from there to add in additional specialties and then into interventions. Let me go to the next slide. Yeah, so this is really what we're seeing. So obviously patient care, much better for them. They stay local, bring in urban medicine, big city medicine to the rural community, by bringing in interventionalists that are coming from Phoenix, Las Vegas, LA, et cetera. The revenue from the hospital, you're currently making $0 a month with these specialties. How can we add that? That's where we want to do that, especially with the interventional side. There's a ton of grants out there too. Other hospitals that we've worked with have gotten grants to cover all the equipment needed for that. That's something that we would get involved with. Again, that business development arm of our company to begin looking at all those options. California especially has several of these. Working on it with another hospital right now on these. So there's that. And then we go to the next slide. Yeah, and so downstream benefits, think about it, like I mentioned briefly, the ancillary revenue that generates from building out some of these programs with imaging alone. Obviously, that can get overwhelming with the number of FTEs, maybe need more techs, which I know is a current issue there. But this is, all the programs that then benefit, whether that be wound care, cardiopulmonary rehab, dialysis, these are all things that we are going to be driving patients to by taking care of patients better, which is a win-win. And it's, oftentimes in medicine, if you do the right thing for your patient, the revenue usually drives from that. And this is one of those things. We'll go to the next slide. Yeah, so this is just our part of our team. Happy to answer any questions on kind of this model, but like I said, I think a very phased approach with this, where we're doing it in some ways a little more backwards of what we typically implement. Most places we begin with some of these interventional clinic. I don't think that's going to be the case with Palo Verde. I don't think that's even an option. I think it's to start on the other side with adding what can we do to optimize first, and then add these as we move along. So I think that brings that to conclusion, at least what I wanted to present tonight, and then we can answer any questions.
We will be asking, we're gonna, allow the public to, ask questions after you all
Okay.
present.
Okay.
Madam President, would you allow public comment after this presentation?
You know,
It's gonna,
so you're reserving the end for board comments and public comment. Okay, it's not an answer for the public, but of course you guys.
so is there any questions?
It's at the end.
So there was.
No, okay, for the board too, okay. Thank you. So can we have the next, what do you guys have next?
Thank you, Dr. Callahan. Next, we have healthcare operators and technology experts, telehealth. We have Andrew McKernan. Andrew, are you with us?
I am. Thank you, everyone. I'm actually going to turn it over to Scott Thompson, who's in operations with us, and he'll walk through this presentation with you all. Scott, are you available?
Yes, I am. All right. Good evening, everybody. My name is Scott, here representing telehealth. We can go to the next slide here. And one more slide, please. Just some quick background on us. Telehealth we'll get into in a little bit later in the slide, but just kind of recapping, what we're seeing here in Palo Verde is we know we're short on cash on hand today. We know about the patients in the district and the local residents, and I've heard from some of them tonight, and the frustration about the current situation, and not to mention the jobs that are on the line. We know that what you are looking for is turnaround expertise, making sure that we have finances for stabilization, a track record of proven success, and someone with a long-term commitment in the best interest of the community there. People who are not looking to change something from what has been working for you all, but to make changes for the better. Next slide, please. So that's where telehealth comes into play. What we're all about is just simply bringing best practices to healthcare. Starting on the left side of the slide, we really all think it really just begins with the clinicians. We take care of the clinicians take care of the patients, and that takes care of the business. So from the left side here, just making life simpler for clinicians. When we do that, we see that patients have better experiences, have better outcomes, and that leads to, again, improved finances and being able to expand services. And everything we're about here is just trying to bring world-class healthcare to anyone, anytime, anywhere. That's what we at telehealth are all about. Next slide, please. So telehealth is a new venture from Titan Holdings. Titan Holdings has a variety of healthcare enterprises. Titan Holdings has multiple companies valued at over $1 billion. We've had 2 successful companies sold, 5 companies that are actively operating today, and 300 employees globally. So this is not our first healthcare venture. I'll speak to one here on the left side. Is Forta Health. This one we started about 4 years ago, and it was really focused on a similar problem in healthcare, which was a lack of access and an operation that was struggling financially. It's really focused in the ABA therapy, which is autism therapy practice. We acquired a small practice and then have applied those best practices. So, making sure we're getting prior auths paperwork done right, making sure we're getting our collections numbers up. And 4 years later to today, it's one of the largest telehealth ABA providers in the country. And, bringing this experience that we know that an ABA therapy practice and a hospital, vastly different operations, but a similar playbook, and bringing that success from our previous operating companies and moving them in here into Palo Verde. Next slide, please. So the key piece here is, we just got done raising money from some investors that are really excited about what we're planning to work on, and we're excited about considering with Palo Verde here, but to try to figure out what does a hospital look like, in the modern day. What are we doing to upgrade some of the existing services that have done so well for so long, but maybe can get a little bit of improvements to help make, again, patients experience better, clinicians experiences better, and get those collections numbers up as well. So we're seeing a lot of really exciting interest from our investors and from the previous efforts we've been working on with other healthcare companies. We're really all focused on, again, bringing those best practices to healthcare and getting the support from our investors and from our other businesses to try to bring that to Palo Verde. Next slide, please. So just a little bit about some of the leadership here. On the far left is our CEO, my boss, Ratankar, who's been really challenging a lot of the norms and conventions in healthcare in a very positive way over the last couple decades. Dr. Chetapale, both of which may be on this call, Dr. Maman, and myself have all had a variety of different experiences. My own experience is in from mechanical engineering, but then brought into the healthcare field and really helping, again, get those best practices, those standards really up. And then the doctors on the team here that really give us a lot of strategic guidance and oversight over the clinical aspects. And as well, people who are not pictured here, we're currently building a hospital advisory board of former CEOs, COOs, and CFOs of hospitals that are currently signing their paperwork right now, so we don't have them any on this slide. But building a team specific to this effort and the potential with Palo Verde here. Next slide, please. So we have a really simple plan. It's not unlike what you guys would imagine, I'm assuming, but phase one for us is all just about stabilization. Just myself, Andrew, who just spoke, some of the other teammates you just saw be on the ground in Palo Verde at the hospital every day. Just making sure we're on site, trying to make sure that we're doing our best efforts to understand what the community is looking for, retaining the staff that are there, rebuilding the community confidence that has been lost, and just really trying to focus on some of the basics of getting those, making sure that we're getting the collections for the services that are being done, some of the low-hanging fruit there. Phase two, we really see as the transformation piece, which is a lot of what our experience is in, which is just bringing technology to healthcare. Nothing that's real crazy, but again, just getting those best practices implemented, making sure things are running smoothly, making sure that we have good staffing models that make sense where people don't have to be doing crazy hours or picking up shifts last minute that cause a lot of extra expense, and just making sure that the programs are being monitored appropriately and we know that there's the right people in the right seats. And then finally, phase three is really where we see growth. So again, getting back to expanding some of the services that had to be shut down. And I think our real intention is with the hospital that we acquire, potentially Palo Verde, really looking at it as a showcase for what community healthcare can be in the modern day, and what could potentially be a case study for community hospitals all around the country, and then also using Palo Verde as a regional hub for also telehealth services for people that may not need to come into the hospital, save them some trips, save them some commute, and then also see those same providers if and when they do come in. Next slide, please. So sort of in closing here, we're really committed to community healthcare. We're all about access. Forza Health, as I was speaking about before, was really all about trying to find those rural and Medicaid families that were getting denied from existing healthcare systems. And again, we've made that one of the biggest providers in the country, and we want to focus that same sort of spirit here at Palo Verde. So we want to, our intention with acquiring Palo Verde Hospital District would be to really make sure we have that end-to-end visibility on finding ways that we can make improvements. We have the budget to turn around a hospital like Palo Verde. We have a team that's been experienced in different healthcare turnarounds before, and again, putting together that advisory board of former turnaround hospital advisors, of CEOs, CFOs, and COOs. And again, our overall goal is, to take what Palo Verde has already built and really carry that forward into the modern age here, and just make sure that it has all the best practices and the latest tech. And I think that's the last slide here. I'm not sure if there's one more. Okay, I know that's it for now. I'll look forward to your guys' questions at the end. Thank you very much for the time.
And thank you.
Thank you, Scott. So we're going to go ahead and go on to the next presentation, which is Rural Centric Care Organization. It's a 1,000-day strategic plan, bridge loan, debt retirement, RCCO, bond issue, new hospital, and grant opening of December 2028. Emergency expedited status. Ambassador here in Washington, D.C., we have Dr. John Raffetto.
Well, thank you. It's good to be here. I'm impressed with all the companies that are making presentations. We saw their materials today and we did a quick due diligence, and they're all reputable, outstanding in so many different ways. And clearly, I see a role for them soon in the organization, very soon. The problems that you're having today are largely my responsibility, believe it or not. The demise of the hospital, the demise of utilization, the demise of revenue is largely due to the managed care movement that took over the industry over the last 45 years. When we started the managed care industry, there was virtually no one in the industry other than Kaiser and a Puget Sound Health Plan and New York Health Plan and a few others. But I would say probably less than 0.1% of the United States was in a managed care plan. And then we started, along with a number of other people, the managed care industry that came out of the HMO Act in 1974, and they started to implement it around 1978, 79. And we worked with a number of major hospital systems in exactly the way we propose to work with you, which is to organize their doctors into networks and manage capital and manage the health plan services that were being rendered through the managed care structure. The managed care structure, as we know now, since virtually everyone in the United States is in a managed care plan. Not quite, but close to 80% of all Americans are in a managed care plan. It's mandatory in most states, Medicaid-wise. Medicare is approaching 60%, and commercial plans are around 75% or so. So the vast majority of Americans are in these networks, and as this industry grew, it emasculated the power of the individual doctor and the hospital. When I started off 50 some years ago in the industry, the hospital and the doctor were king. And as your chief of staff will tell you, Dr. Salobi, he'll tell you that things have gotten difficult for the doctor through the years, primarily because of managed care. In the case of, I'm very familiar with Riverside County. We worked for the Riverside County Health System years ago. We evaluated the entire county from Riverside to Temecula. They didn't even call it Temecula then, they called it Rancho California. And I believe that Blythe at that time was bigger than Temecula today, is today. The county, the Riverside General Hospital is what it was called then. We did a long-range plan, which resulted eventually, not immediately, in the relocation to Moreno Valley, where it is today, and it's a very successful operation. We worked with a number of other hospitals in the county and in San Bernardino County and Southern California generally. So I'm very familiar with the situation, and specifically in Blythe, what's happened is that the HMOs, Molina and Aetna and Blue Shield and Health Net and IEHP and the rest of them, they very quietly, when it expanded into the rural areas, like Needles, like Blythe, and they ended up signing up most of the people. And because the hospital had limited resources and an old facility, which has to be replaced if we're going to have any kind of success there, They sent the patients into San Bernardino, Loma Linda, Coachella Valley, and elsewhere. And that pattern has continued. And if you look at the statistics, patient days, revenue, it's just downward trend, starting a few years ago. And what we aim to do is to capture that entire market, which is well over $100 million, believe it or not. Over $100 million of medical services are rendered to the people of Blythe, but mostly outside of Blythe. We intend to capture that business and bring it back into Blythe and end up with a facility like what I assume you can see this image on the screen. This is what a new Palo Verde Hospital could look like. It's actually Scripps Clinic in La Jolla, which is an old client. We actually created that hospital there with the architect Edward Durrell Stone. We at the time, Scripps was a small organization in downtown La Jolla in the Village, and they needed to expand. They brought us in to do a master plan, a long-range strategic plan, and we said we have to expand our license capacity. We have to expand our bed capacity. We have to expand and diversify our outpatient services. They were largely a group of internists and radiologists at the time, very sophisticated diagnostic work. We proposed an expansion of services. And we said we have to move to a new location, just like your hospital has to move to a new location. And if you're familiar with Eisenhower, I view that as a model, of course, on a smaller scale for your hospital. I envision, a 25 to 50 bed hospital, depending on what the evaluation shows, that can accommodate not only the people who are there now, which I understand is somewhere between 18 and 20,000 people, but a new and vibrant Blythe in the coming years as this becomes a retirement community as well as a community for businesses. Blythe can have a fantastic future. One of the precursors of such a movement is a fantastic hospital. You have to have a fantastic hospital, and you can. You can have a fantastic hospital, and you can have a lot of specialists there on site full time. And what you can accommodate full-time is accommodated part-time. And then, yes, there will be the referrals occasionally out to the Coachella Valley and other sophisticated medical communities around. But for the most part, you'll be able to take care of about 80, maybe 90% of the services right there in a sophisticated facility with a panoply of doctors. This approach that I'm talking about is called a role-centric care organization. It's a managed care entity. So you have the hospital right now, and that hospital is owned by the district, and it should stay owned by the district, although it could be sold. You have a couple of proposals on your desk now they want to come in and take over the hospital, and I can see why. You have $100 million market that you're losing every year because it's going elsewhere. Anyone coming in is going to know that that is a $100 million market, and possibly even larger than that, because the per capita clinical services tend to run around 10,000 a person, nationwide, 10,000 a person nationwide. So if you have 20,000 people, that is a medical economy, annual medical economy of $200 million. So we go with 100 million for now. It's a conservative number, and we'll fine tune it as we get into it. But it's a big deal. You're sitting on this huge opportunity. And I know there's been a lot of infighting and all that. I've seen all of that before many, many times. We've worked with many district hospitals through the years, and county hospitals, small ones, large ones like El Camino and others, and Tri-City, but we've seen small ones as well. And there's always infighting, there was always jealousy, there was always finger pointing, all this. I would recommend that everyone just stay where you are, remain on the team, and let's get moving very quickly in bringing this forward. And I see a role for all the organizations that have thus far made a presentation. I can see telehealth. They're mainly an artificial intelligence organization, very reputable, very advanced, and but they're brand new in, Pala is a brand new company. That's fine. That doesn't mean, that they don't have the ability to bring people together. And obviously, they've brought some outstanding people together. We heard from one just now. And so I see a role for them with the RCCO. The RCCO, the Rural Care Centric Organization, needs outstanding managed care techniques, which are based on value-based formulas and artificial intelligence and working all this out. So there's definitely a role for telehealth. The group out of Las Vegas, they're offering some services as well that I think are highly important, and I can see them coming in actually in the interim fairly quickly. I can see all these companies coming in fairly quickly, actually. But when it comes to the group out of Las Vegas, they the next phase for you over the next 3 years is keeping the hospital going, gradually building, rehabbing it to some degree, bringing in new equipment that's needed, reopening the inpatient services, which is a must, and kind of keeping it together over the next 3 years until the RCCO opens. And once it opens, you'll have contracts in place with all the different health plans. You'll be able to redirect the patients into Blythe as you build up physician manpower resources, and it all falls into place like dominoes falling on a table in your den. It all comes together very nicely. The brand new hospital opens in 3 years. And let me correct something. I said that the RCCO, the Rural Care Centric Organization, would open in 3 years. No, it would open in about a year and a half. In a year and a half, the RCCO will have already negotiated with most of the health plans. And there's a conversion process that goes into place with Molina. They all have different policies and procedures. There's an annual calendar that we have to abide by with respect to the state and federal agencies, CMS. But basically, the RCCO, which is a local entity owned and operated by your group. It doesn't have to be the district, although it can be the district. It could more than likely be a nonprofit or even a for-profit affiliate of the district. And this entity is basically yours. It's based in Blythe. You are in control of it, and it will contract with Palo Verde Hospital and all the local doctors. It will bring in new doctors because it will have an operating budget of 50 million probably the first year, and the second year probably close to $100 million. And that gives you a great deal of money to work with in terms of recruiting physicians and making changes to the hospital and doing all the things necessary to enable the hospital to evolve significantly, but not dramatically, until the new hospital opens in 3 years. So there's several phases. It's spelled out in detail in the proposal that you have in front of you with a timeline. It's all laid out, but I didn't want to get into too much detail because it's a kind of a complex issue. So in a nutshell, and I forgot to mention the group out of Calexico. The group out of Calexico is they're a reputable medical group practice, and they're in a agricultural area, really, Imperial Valley. It's a thriving county. Recently, a district, a district hospital there in Brawley, Pioneers Memorial Hospital, has changed the name of the district, and they're in the process apparently of merging with the city hospital in El Centro. There's a lot going on in Imperial Valley, and they're really very smartly taking control of that community. Now, the group in Calexico is doing well, as far as we can tell, based on public information, and they could definitely play a role in this new venture that we're calling rural-centric care. So the RCCO is the answer. Capture the business, capture the $100 million, potentially $200 million economy that's generated every year. Build a new hospital. We propose, if you read the proposal, we're talking about organizing a long-range facility planning committee that would involve all of you for the purpose of coming up with the plan for the new hospital. And that committee would be organized in February or March. And it would be a committee that would evaluate all the data that's important to evaluate when you're planning a new hospital like the one in front of you, which, as I said, we planned. And you come up with a master plan, and you decide this is the hospital we're going to have, this is the new site we're going to have, and it'll probably be a site with a lot of acreage. I imagine that acreage can be acquired for less in Blythe than perhaps Newport Beach. So I would propose that you buy one very large tract of land, if you can, somewhere in the 50-acre to 100-acre range, and master plan it for the hospital, a medical building, assisted living facilities, convalescent hospitals, the works. And eventually, remember, we're talking about a 10-year plan, and make it large enough and spacious enough so that everyone can, who wishes to, come into Blythe and set up an organization medically that's compatible with what we're doing. In a nutshell, then, in summary, what we're talking about doing is capturing the market that's currently almost exclusively enrolled in HMOs. Not entirely, but most of the Medicare beneficiaries in that area are in a Medicare plan. Some of them are Medi-Medi, meaning they're duals, so they're in a Medicaid, Medicare, or Medi-Cal Medicare plan. The plans are sending these patients into the Coachella Valley for care. They have to understand that a new hospital is coming, and that a new organization of doctors is going to be in place there that will be able to treat all the needs of the patients locally, and they will move those patients into this rural-centric entity that will be contracting with them. Let's just take one plan as an example. It's a complex issue. It's a complex plan, but it's so it requires a little repetition, and excuse me if I'm repeating myself too much, but what we want to do is we want to take a plan like Molina and say, we have this rural-centric organization. We have all these doctors under contract locally, as well as in the the distant areas like the Coachella Valley, like Loma Linda. We have to contract with them as well, because we're going to make a transition with the Molina patients who are already being treated in remote areas, Palm Springs, Rancho Mirage, Indio, etc. We're going to take those patients and put them into our own organization as a subcontract with Molina. So Molina will still have the patients. They will transfer those patients to us in terms of the management of their care. And so they will pick up a % of the premium that Medicaid and Medi-Cal and Medicare will be paying them. And we will pick up a bigger percentage because we're responsible for the rendition of care. We'll go to IHP. They have 5,000 or 6,000 patients in the area. We'll negotiate the same thing with them. The state will back us in this effort to work with these different plans because the plans are violating time and distance rules. Right now, they're sending the patients 100, 250 miles away. And if you're having surgery in Loma Linda, that's 3 to 4 to 5 trips when you talk about pre-op, surgery, and post-op. So it can amount to 1,000 miles of driving. The state of California, the Department of Managed Care, and Medi-Cal are both very unhappy about patients having to drive great distances. So accessibility is being violated on a regular basis. And we, with our rural-centric organization, having the ability to centralize the care with a plan that will result in a new hospital and dozens of doctors, maybe 2 to 3 dozen doctors or more. They will work with us, and they will work with the health plans and help motivate them to work with us to handle the treatment of patients. Yes.
Apologies for the interruption, Dr. But your 20 minutes are up. Do like a few minutes just to wrap it up in like 2 minutes, just so we can allow time for the next presentation.
Yes, thank you so much. So, in a nutshell, we're talking about going to work right now with your team, which I think is outstanding. I've met with Lena Wade. I've met with Vanessa Burke. I've met with Mike Love. I know Sandy Anaya, and I want to join their team and right away without any hesitation and get started on basically an emergency plan to bring in as much capital as possible on the basis of a donation or a loan or an investment in order to give you the capital to remain in business and reopen inpatient services, and to do this very quickly, literally within maybe as quickly as 6 weeks. To bring in enough capital to do this, there is this IGT transfer situation, which may or may not be available to us anymore because of the deadlines. But I want to come in immediately and start this process of doing an emergency business plan that explains the long term to the investment community, which includes the government agencies, the state and county. I want them to realize that there is this opportunity to centralize care, and that there is $100 million market that can be controlled by the people in this very room. So if they see that plan, they and the investment community, and we're talking to potential investors right here, these companies that are making presentations, they might be willing to come in with an investment and come in with a short-term loan to get us through the next phase, which is the bridge loan that I see forthcoming that will carry us through for the next 3 years while we're building the new facility and opening the new facility in Christmas of 2028. So that's my presentation. Thank you.
Thank you, Dr. Pero. So our next presentation is going to be your purchase and transaction agreement for privatization of a hospital. We have Legacy MD Medical Group, a California professional medical group, El Centro. We have Dr. Vo, which he is here in person, and we have Alex.
Yeah, Alex, good afternoon, and my name is Alex Parkin. I'm currently the business development director for Legacy MD. We also have the founder for Legacy MD, which is Dr. Vo. We have Luis Minor, who's our compliance manager, and we have Edith Esmeralda Diaz, who's our CEO. Folks, I'm not going to take a lot of time, but I do appreciate all the passion from the community. We just want a fair opportunity to present a unsolicited proposal as discussed by the mayor, and in full transparency, we do want to be able to unveil this proposal that we think will be something for you folks to consider. Again, the community of Blythe is something that we do appreciate, and I just want to give you a background. If I can pull up the PowerPoint presentation, or do we have a PowerPoint?
We do.
We do or don't? Okay, so just real quick, what we did, and we're not new to Palo Verde, and again, I would encourage you to reach out to the superintendent for Palo Verde School District. We've cut our teeth in being engaged with the community. For the last 4 years, we've been conducting pop-up health clinics at the Palo Verde School District. We've probably seen over the last 4 years, 2,000 patients there. Everything from sports physicals, immunization clinics, COVID vaccine testing, and health and wellness checkups. So we're not new to the Palo Verde community. Again, our relationship started with the Palo Verde School District and driving over here once a quarter and providing those clinics. Most importantly, to improve the truancy at the school district. So nothing new when it comes to us representing this community. We're also not representing any type of pro forma type of situation. This is real deal. Legacy ND currently has about 70,000 square feet of brick and mortar healthcare clinics between Riverside County, Imperial County, and San Diego County, specializing in rural and disadvantaged communities. Again, this is nothing new for us. This is something that we do every day. Our current patient census is an average of about 400 patients a day. We have 22 providers. We have 12 NPs. This is nothing new for us in terms of where we're at. Again, having the opportunity and full transparency to unveil our proposal is something that we do appreciate, and we're open to any types of questions. Back to the presentation here, what you will see in the second slide there, if you can. Sorry. That's all right. It's PowerPoint. As we look at you look at the 65,000 square feet of brick and mortar healthcare facilities that we have everything from primary care, specialty care, urgent care, labs, imaging. We also have an ambulatory surgical center as well. We're also in the process of expanding our SNF from 30 beds to 60 beds. So it's something that we're very proud of in terms of being offering these services. Why are we here in Blythe? You have 18,000 plus residents. You have Interstate 10. This is a natural environment for us. Being in a rural and disadvantaged community is something that we do every day. Again, we're not here representing some sort of pro forma type of situation. We're not asking for management fees. We're not asking for any of that. We don't have any Wall Street interest. What we do is have your interest, and that's why we're here today. We don't have a 10-year plan. We have a 1-year plan. That 1-year plan is to keep those doors open. And that's why we have before you an agreement for your consideration that would allow for you guys to vet us and we vet you as far as what is in the best interest of this community. Closing that hospital is not. We cannot close that hospital. That hospital and those doors and those licenses need to remain open. And that's what we're here to do. Again, we're not asking for a management fee. We're just asking for a partnership opportunity so that we can grow together and then look and explore the possibility of a strategic acquisition. Nothing that's done in one day. It's a 5-year proposal that we can look at and really see if this is a good fit for both of us in this community. One of the things that we do specialize in, I'm going off script here, so forgive me, but one of the things that we do specialize is grant money. Right now, we have already identified how we're going to, in a joint partnership situation, how we're going to go ahead and raise this money. And it's through B-CHIP funding. We were recently a recipient of a $20 million B-CHIP loan. Only 3 for-profits were awarded that in the state of California. Legacy ND was one of them. Why? Because we're expanding our 30-bed SNF to 60 beds. And that is happening today. The team that we have put together to deal with HCI regulations is stellar. From civil to architect to construction management. We are now in the process of dealing with HCI permits to expand our SNF due to this award. Our partnership is a partnership where we can work with the district, work with the private provider, and chase the B-CHIP money to provide the tenant improvements that we need at Palo Verde College. Back to the PowerPoint, I apologize. So there is a cadence. What you have before you for your consideration, again, is possibly looking at a letter of intent, possible strategic acquisition. But we're not talking about survival. We're talking about improvement and expansion. That's kind of the space that we're looking at. We have a team. Let me go ahead and jump to the next slide real quick. First of all, this is the cadre of positions that we have, again, from the 22 providers, from the 12 MPs. Recruitment and retention is not a problem. But we're looking at a hybrid model between the existing talent that you have here and the talent that we have. We already have a short list of people that are willing to come in here and get to work. Starting with the emergency room, working our way to reopening, and quickly getting into the expansion, pursuing the beachhead funding, bringing our construction management team, bringing our architects, bringing our civil group, and start dealing with the HPI issues to expand this hospital. That's just kind of a general overview of what we have. Again, this is not a pro forma situation. This is in existence right now in 3 counties: Riverside, San Diego, and Imperial County. Next slide. Specialty care is already in existence. We're not talking about recruiting. We're not talking about retaining. This is already in existence in terms of the services that would be available immediately to the Palo Verde community. Next slide. As far as what we're looking at is a purchase and a transition proposal that, again, in full transparency with community input, as far as what this potentially would look at. This is just a stick man. We want to put pen to paper. This is what we drafted for your consideration. We welcome the red lines. Bring us the red lines. Talk to legal, talk to your community, talk to your trustees. Provide us the red line. We just wanted to provide you a document that you guys can look at to show that we are serious and where we want to be and why we want to be here today. Next slide. Purchase and transition. Again, we do have a little bit of homework on both sides of the equation. You know, we really want to look at some of the financial disclosures. We want to get into the financial. We do want to get and take a peek under the hood to see where we're at financially. But we know that the 18,000 plus people here in this community deserve access to quality healthcare. We're willing to take that risk. We're willing to partner with you folks. Next slide. Some of the recitals, just some general stuff. Again, we do have some information. We're hopeful that the community can read some of this. Let's go ahead and jump to the next slide. Some of the definitions that we laid out in the term. Again, we are asking not only the community, but your legal look at some of the definitions that we're using just to make sure that we're all on the same page. Next slide. You know, some of the transition and management period, again, we're looking at a 5-year period for consideration. We can go ahead and either do this as a sprint or do it as a marathon. Our preference is to do it as a sprint. You know, again, with your surveillance, with your input, with the community input. But we've laid out some operational duties. We talked about a 5-year transition. Again, this is a stick man. This is a stick man for you guys to review. You to redline, you talk to your constituents and add so that they can have the input. Next slide. Guys, again, we're not asking for money. We're not asking for management fee. What we're proposing is that we will make a $3.5 million investment into this hospital by November of 2026. That $3.5 million is incredibly important because it does provide a cash match that you need to get the other government funding. Again, we're not asking for a loan. We're not asking for a management fee. We're here to bring 3.5 million to you guys by November of 2026. What we would do in this 5-year period, again, is pursue beachhead funding, pursue grants, pursue other federal funding. We have already a very proven grant writer who was successful in getting us the beachhead funds needed to expand that SNP. And have put together this incredible construction management team to deal with the expansion of new construction that is HCI regulated. That is not an easy task to deal with. Next slide. For your consideration, You're looking at some of the operational enhancements. I'm getting above my pay grade in terms of some of the things, everything from ICU, the swing beds, the telehealth, the pharmacy, the specialty service lines, all of those what's available. But here's the most important part, right there, governance and oversight. Governance and oversight is these people right here, along with the trustees, where we can come together and provide the governance, provide the oversight. We're not here to dictate to you. We're here to listen and provide services. We cannot do this venture without the appropriate governance and oversight. And this is what we're proposing. Parties shall establish a joint governance procedure. We're not here again to dictate and tell you. We need to be held accountable by the community. And this is what we're proposing in terms of our potential acquisition of the asset. Next slide. Transfer and ownership, something for you to consider, subject to an appraised value of the property is, again, if we bring in the 3.5, we pursue some significant tenant improvements, equipment, et cetera, is before you for your consideration. We're not dictating, but for your consideration is a mutual agreement and a transfer of the asset that we can continue to keep those doors open with significant investment and significant enhancement to services. Next slide. Some of the conditions and precedents, again, obviously just some generic termination or exit strategies for both of us in case this marriage is not something that this community wants, or basically they're not happy with our performance. Next couple slides. Some exhibits. These exhibits, again, is for the community to review what we can potentially bring, the enhancements, the opportunities for improved services, just a list of exhibits that for your guys' consideration. Next couple slides. These are pretty good night. Some revenue enhancements, and the other presenters did a great job. You know, we talked about revenue enhancement. You know, and these are areas that we definitely would look at, but you know, 400 patients a day, we know how to build. We know how to build. We have a compliance director here. We have a CEO. We have a founder. It's a natural habitat for us to be in this field, making sure that we are compliant, making sure that we are dealing with the regs and increasing and maximizing the revenue. Next couple of slides. Some of the expense management, obviously, you know, a 5-year agreement allows us to look up under the hood, see where there's some efficiency improvements, look at some areas where we can enhance revenues, other areas, again, where we can improve customer service, subject to the participation of this community. Next couple slides. Expansion and service. This is the fun part. You know, you guys have Disneyland here. Disneyland is the hospital. Let's rebuild Disneyland. Let's rebuild Disneyland. Let's go ahead and make some serious investments. Let's improve services, not only to the 18,000 people, 18,000 plus people that live here, but all those people that drive on Interstate 10 and get them off the freeway and know that in case there's an emergency or some sort of medical situation, that they can pull out the freeway and get quality care with dignity. Next slide. Questions? So I'll stop right there, folks. Again, thank you again for the opportunity. We're just here to enhance, and again, we're open and fully transparent. He's gonna try to catch me. All right. But we're here and very open to anything, any questions you have to deal with, address them. But I'm gonna hopefully, Madam Attorney, yield a little bit of time to this.
Yeah, thank you. Thank you. You have time, right?
Yeah.
Okay. Yeah, I just want to say very quick because really we're here, we are big with community. And we came here not because we want to buy a hospital or we want to do anything to the community, but we want to help the community. That's all. That's all I have to say. Really, and the trust from the community. But if you guys trust us, not going to be successful. Because you have to come to the hospital, you have to come one of us. If you go to another hospital or you go to another city, we can't do it. We have money, but we can't do it. We can't convince you that we're good, that we can go by. So that's the key here. I mean, it doesn't matter all the presentation, everything else. You can say whatever you have to say. You have $1 million, $100 million, but the community don't trust you. Nothing you can do. Is that true? Really, they are the one really decide to come to the hospital. I cannot force them. Hey, can you come to my hospital? Can you come to my clinic? Right? So really, that's the bottom line. We do talk to the CEO, not because we want anything, but we want to do some more details. So can we do this? Because I don't want to come here and waste your time and our time and say, oh, we can do this good. But again, the bottom, we cannot do it. That's it. You can listen to anything, but again, we are very transparent. We even emailed the attorney about us. The bottom line, if you don't know enough about the hospital, why you want to say, hey, I can do this? That's it. So, and then again, strong community support, that's really what we're here for. Because really, if you guys don't trust us, we can do this. Number two, we want to build a health plan. Just like the ambassador care doctor said that we need to have all CCO. We have to have, because he's mentioned about HMO. We don't.
Héctor, apaga tu furia. Oye, ¿no vas a trabajar?
Okay.
Okay. So yeah, so I think we have to go with the trend. We have to go with the flow. We cannot go against the river. That means we have to go to action. We're gonna build our own health plan. Technically, if I have my health plan here, I don't care about Molina. I don't care about ISP. You don't pay me, no problem. I'm gonna ask the trust of the community. Hey, please join our HMO here. Because we're gonna build a strong foundation for you guys to come in and help us, help the community to grow. That's the point. Why we have to depend on other health plan? And we talk about in Peel County, we have our own health plan now. We do have our own health plan now. So that means we can negotiate all the health plan that want to come in, have to pay higher rate. Otherwise, we don't need them. We have our own. We have our own hospital. We can become the hub. We can become everything that we can do. That's the potential that I want to come here to bring to the community. So I hope that strong support. Again, if the community don't want us to come, okay, no, really, it's a lot of headache, I know for sure. We come here, we know that we're gonna have a lot of headache, a lot of problems we have to solve, a lot of things we have to do. And we don't ask you to, hey, give me money so I can help you. We put money in to help you. So if you don't trust us, we go home. That's it. Really, we can't do anything else. We just talk to each other and then, you know what, and then they could suffer. The community, the people. Yeah, we have a good idea like Las Vegas, cath lab. But we have to slow down. We have to do strong foundation. We have to build a volume, build a trustful community. So that's why my presentation also we say the main thing, community first. We successfully in Peel County because you look at my Facebook and everything, we involve with the community. We not just say, okay, you know what, we're the best, come to see us. A lot of people talk better than me for sure. I don't talk good, that's why I let him talk a lot. I'm here to work, to execute. That's my thing. I was a hospitalist. I know how to run the hospital. I was the medical director for the ECMC hospital. That's why I came in, I look at this hospital, I think this really, we can turn it around. Otherwise, really, I don't want to be here to waste your time and my time. Really, we don't have time for that. Yeah. So yes, so I think in another word, we're gonna talk to all the community because if you agree with us, we're gonna come out the community, talk to the city council, all the people here, the leaders here to see if they're okay with us, the plan, because that's what he said. We need the community to support. We cannot do alone. Strong foundation, strong community, and strong volumes. Because if the whole 18,000 here join with us, you see the number from that ambassador care role you give it to you. We have a lot of $1 million. Yeah. So if your family come to me, your family come to us,
to the hospital to help them. And again, hospital don't, right now, hospital, we don't need to expand more beds, but we expand more outpatient services. Because I don't want you to be sick to come to my hospital to make money on you. Does it make sense? So we want you to be healthy to come to my outpatient clinic. And the money, Medicare, pay for our health plan, keep it to treat you guys well. If you guys have well, you don't come to a hospital, we have a lot of money extra. Does that make sense? If you come to hospital multiple times, we're losing money. Because you pay a lot of expenses, hospital is too expensive. So that's simple concept, that's really simple. We want you to be healthy, don't come to hospital, Medicare for insurance pay us. We keep it the outpay, then that outpay will help you to stay healthy. So we coordinate all that, all CCO, we talk about that's all CCO, that's a coordination of all the case management, LN, LVN, all that doctors. So technically, we're gonna call your family all the time because, hey, did you see the doctor? Because you want to see the doctor, so you stay healthy.
Dr. Bell, I apologize, Frank. Would you like 2 last minutes so you can just wrap it up?
Yeah, I just received 2 more questions. Okay, so I think, again, I am here to help to contribute to the community. That's all, really, nothing more than that. Really, we're not here to compete with anybody. But I think with those proposals, we can come together, we can see, they have all good things, bad things, to come together and we make it good. But we're not gonna promise that we're gonna boom in the next year. We're gonna do step by step. But for me, the speed, we are very fast. Look at our in Hill County. We opened the office in 2014 with a 1,400 square feet. Now we have almost 100,000 square feet buildings. 100,000. Yeah, so that's how we from 4 employees, now we have 150 employees. Yeah, either we're not hospital over there, but we have MRI, CAT scan, imaging specialists. We keep recruiting more and more. Actually, the volume go up, it's easy to recruit specialists. If the volume is low, nobody gonna come. So that's why I want to be a community, church community. I'll go out here, live here, I'll go to school, whatever. We have to talk to them, gain the trust back for the community, and I think we'll be successful. That's all we need. It's very simple concept. I don't care you invest $1 million here, but people don't trust you. Not gonna do it. All right, thank you.
Madam President, I would like to propose a 10-minute break just to allow for a restroom break.
Yeah. Okay, we will have a 10-minute break. Okay, we'll bring back this meeting back to order after this break, and now we have a question. So is there any board questions regarding the presentation to the presenters? Does anybody have any questions? Let's start off with Trina.
Your presenters are still inside.
Trina, can you hear us? Are you muted? You should mute.
Not muted. Trina, can you hear us?
Okay, yes, I can.
Yeah, I just wanted to know if you had any questions regarding the presentations to any of the presenters.
I have a lot of questions. I just want to thank Dr. Callahan, Scott, Dr. Vo, Alex, Dr. Raffetto for their time and interest in the district and submitting their proposals and how we can provide excellent care to the community. Is there any possible way to have another discussion in terms of, after tonight that we can ask more questions. I've met with Dr. Raffetto before and Alex and Dr. Vo. They're doing great things down in Imperial County. The telemedicine is wonderful. It's a lot of rural hospitals that are engaging in telemedicine. Our problem is, we have no physicians and specialty services. Also, the cardiac care
That's right. That's
that
right.
our patients desperately need. We don't have a lot of time. So we need to move forward as soon as possible to implement these things and come up with a strategic plan immediately. I'm open
Absolutely.
to whatever I can do to, as a board member. I think I speak for the board. For the most part, we all want to do everything we can. We just have so many issues, billing, and I mean, a lot of things were brought to the forefront. Dr. Raffetto brought up a lot of really important things. This has been an ongoing issue with the hospital. The prison, we had prison closures. We've been through multiple CFOs. We've had billing challenges, just problems from A to Z. We have a very old, antiquated hospital that has a lot of operational issues in terms of, generators, chillers, just boilers. It's from A to Z. And Dr. Vo made some very important comments too, in terms of, earning the trust of the public that we can provide good care and that they would be, safe with the hospital. And with all this political negativity going on, we have to stay focused on
Exactly.
the
You have to.
hospital.
You have to.
Yeah, or else who's going to suffer in the end? It's going to be our community. And that's what we
Absolutely.
all need to remember,
Yes.
it's so I'm very, very grateful for everyone that is on the Zoom call. Thank you all for taking the time out of your schedules to be here. Thank you to the community members that are participating, people that are trying to make a difference in a good way besides slander and point fingers. I believe that Blythe is a very, very difficult, it's a very difficult landscape there with, the payer mix and the rural area, trying to get staff. I mean, it's a lot. I've been in practice for 40 years and worked at a lot of different hospitals, and Blythe has a lot of unique challenges, and anyone that will step up and help us, to provide better patient care. That's what we have to remember here tonight, is to try to work together as a team, as a community, as a cohesive group, to get through this. We were meeting with the cardiology group out of Las Vegas. I think that they do have a very good model that they implemented there in terms of reaching patients for interventional cardiology services. So they don't end up in the emergency department with a STEMI or something. And, our community I feel, has, not been afforded the opportunity because of our location, the rural facilities. out there, not having the services, it puts a real strain on families and patients. So I'm open to whatever I can do to supporting our community and the healthcare needs. And Alex and Dr. Vo, I know that you did a lot of great things over at the high school, reaching out in that way. I know that you've worked hard down in Imperial County. Thank you again for being here. Dr. Callahan, thank you. And Dr. Raffetto, thank you.
Thank you.
And Scott too. Thank you all very much. It's
Thank you.
it's a lot to process, you don't
Yes.
you want to make the best decisions for success for the hospital and for the community.
I'm sure all of us are available to talk to you further about anything you want to discuss and answer any questions you may have.
Yeah.
When I say all of us, I mean Dr. Vo, Dr. Callahan, and the other presenter. I'm sure we're all available.
And Dr. Callahan, I like the idea. I know that when you came with your CEO, and we met, you took a tour of the hospital. I think there's so much potential there too, in terms of utilizing the hospital. If we can get the specialty services here, and there's a need. We have a lot of patients with a lot of comorbidities, and I think that would be a vital service to the community.
I agree with you. What we have to do is we have to put together this rural-centric care organization, Trina, in order to capture all that managed care business. Then everything else falls into place. Dr. Callahan's company will be very valuable. Dr. Vo's group will be very valuable. Tala will be very valuable. It's capturing that $100 million market through a licensed organization called a rural centric care organization. It's licensed by the state of California, and it would all the health plans will do business with us, even if they don't want to. And why? Because we're offering to centralize all the care in Blythe, most of the care. And all these plans are violating time and distance rules. And it's a big problem. And they suffer as a result. Their patient satisfaction ratings go way down because the patients have to travel. So they'll benefit by more revenue per patient. Their capitation will increase when they improve patient satisfaction results. So everyone's going to benefit, but that's step number one. And these organizations, all of them that are here, they're wonderful. And I can see a role for all of them.
Right. Dr. Raffetto, I have a question. How many hospitals in California have you ever had the exposure to all the challenges that our hospital is facing? Have you worked with other rural hospitals in California in terms of?
We have worked with many rural hospitals, including Needles, for example. We did their long-range plan, which they implemented, and now they're going to have to do another one in order to build another new facility. That's an example. The Hemet Valley Hospital was way back in the 80s and went through a very extensive planning operation, the Riverside County organization, and on and on. The Association of California Hospital Districts, we were their favorite consulting group years ago. The whole managed care, we helped establish Pacific Care. Pacific Care became the largest Secure Horizons, largest Medicare plan in the country, or one of them. And it ended up being sold to United Healthcare, which put United Healthcare on the map. United Healthcare today is a $400 billion organization. And that's due in large part to the acquisition of Pacificare. And what did we do for Pacificare? We organized all the doctors and all the different hospitals that the Lutheran Hospital Society owned for the purpose of capturing all the business that they were going to generate through the HMO. And so what we're proposing to do for your hospitals is basically the same thing, organizing a network of doctors locally as well as in the far-flung areas like Palm Springs and Loma Linda in order to bring about a transition where we end up centralizing the care over time. It will take about 3 years. The new hospital has to be built in order to centralize care fully. But by the time the new hospital opens, which it can in 1,000 days, we will have 25 to 30 full-time doctors in Blythe. Because why? Because we will be controlling a $100 million cash flow river of money coming in from all the plans. All the plans are going to contract with your organization, which I'm calling Rural Centric Care Organization. That'll be your organization, the districts, and it'll either be owned by the district or it will be set up as an affiliate nonprofit or for-profit. And that entity licensed by the state will subcontract with all the different plans, IHP, Molina, Kaiser, Aetna, Blue Shield, HealthNet, etc. They'll all funnel their money into that, which you will control. Your group will control it. And you will then divvy up the money to all the different providers, including Palo Verde. Palo Verde will be subcontractor to the Rural Centric Care Organization. So the district basically is going to evolve from a hospital organization to a managed care organization. And it will also own the hospital, or it could sell the hospital to Dr. Vo, or it could sell the hospital to Tala, or other organizations. I mean, you don't have to stay in the hospital business, but where you really want to be is in the managed care business, which is above the hospital, above the doctors, managing all the money and centralizing. When you manage the money, when all the money is coming to you, you are then able to direct referrals, to direct admissions. And with that $100 million budget, which will be spent for the next 2 years anyway, to some degree outside of the area until you build up the resources, that new hospital is going to come along and it will accommodate virtually everything. And
to interrupt Dr. Rufetto, but Madam President, just due to time, would you like to limit the comment period?
Yes, I think that'd be appropriate, because we need to give the same opportunity to all the other presenters to be able to answer questions and keep it concise.
I do have a question for Scott too, if I may.
Yes.
Hi, Scott. Hi there. What kind of telemedicine specialist would be available to our community? Do you have like infectious disease, endocrinology, wound care? Those things we have a lot of patients that have a lot of comorbidities, like I said earlier. What kind of initial, first of all, have you ever worked with the California Rural Hospital critical access facility? I can't hear you.
Madam President, would you like to limit the response to 2 minutes, or would you like to time it?
Yeah, yes, but what would be the appropriate time, the appropriate minutes?
1 to 2 minutes.
Whatever you suggest.
Okay, yeah.
I think a study session would be more appropriate.
I do too. I agree with that. A study session I agree, might be better.
But for tonight, we can answer the question. If each presenter can have the same opportunity to answer the question, we'll do it in 2 minutes. If they can answer something in 2 minutes, and then, for future, we'll see, we'll look at a study session.
Yeah, I know we don't have a lot of time, I understand that too.
Am I coming through now?
Yes.
Yes, go ahead.
Okay. Perfect. I'll be very brief then. To answer your question, Trina, the plan that we would be building for Palo Verde would be something that we'd be building with you all and for the community there. So we're looking at the needs of the community in Palo Verde and in the district, and for the telehealth, telemedicine people you were talking about, we would kind of develop that with you all. There's not staff that we have ready to kind of deploy day one.
Okay, how long would that be? What kind of timeline? Because they'd have to get credentialed and all that. That's another concern I have.
Right. I don't have a good timeline estimate at this time, but I can follow up with more information later.
Okay, yeah, there's just a lot of things that need to be answered. And we, like I said, we are up against a critical timeline, and I know this IGT funding is critical for the district as well.
Right. Trina, one of the things that
Do you
we
have another
propose.
question, Trina? Do you have another question?
No, I just hope that that's at the forefront here, the IGT money, because I know if
It
we don't.
absolutely is.
My understanding is if we don't participate in that, Carmela, that we're not, and we get our reimbursement for what we put into it 2.5 to 3 times the amount of money. In the past years, the hospital, that's helped us tremendously financially. And if we don't participate, my understanding is that we would not be able to participate next year. Michael can touch on that maybe later. So I just bring it up because it's so critical. But thank you. Yeah, so maybe we can look at a study session quickly, by Zoom or something, and have the opportunity to ask more questions. I don't know.
I would propose as soon as possible, because the IGT funding is important and there is a deadline that has to be extended, and it hasn't yet been extended, and if it doesn't get extended, then it's over, and that's this Friday. But as Vanessa Burke will tell you, it could get extended, and one of our proposed roles is to raise $3.5 million within a 4 to 5 week period in order to meet that IGT funding requirement. We initially proposed to come on board in October, but it was delayed. And had we done so, we might have the money now.
Point of order, ma'am.
President Garnica, may I ask to be recognized? This is Vanessa Burke.
Yeah.
I'd like to call a point of order. This is completely illegal. This is real property negotiations going on, and you have not noticed this meeting for this purpose.
That's not accurate. So let me just say this. This is an opportunity to present some proposals that have been received and just get the discussion started. So IGT discussion, that's coming up later. As with any other agenda item, there's a question and opportunity, public comment, and then wrap it up. So this isn't intended to be long. This is, again, is to get this out to your public and your board, and that's it.
Do you have any questions that we can, that can be asked to another presenter?
Can you repeat that? I'm sorry, you broke up.
If there was another, she had a question, she had another question.
Right, there will be a study session at a later time. This is just an opportunity again for these presentations and to move forward. There is a very heavy calendar or agenda. So this is just, short questions. If you have some, they'll be coming back. We're gonna get direction from the staff, from the board at the end, but this can just be wrapped up soon.
Okay.
So is there another board member that has, any other board member that has any questions for the presenter?
Hi, Trina. I would just, what, am I on? Okay. Thank you. I just have a question about, human resources. Is there a game plan for that so that people in the community can, I don't, I'll leave it at that.
Is that any special presenter or that's just a general question?
Just a general question.
Is this a general question that anyone can answer?
In 1 minute.
Okay.
Yes, we can do it in 1 minute.
I'm sorry, and by the way, I'm sorry if I created a problem by, I'm just trying to be helpful. The human resources, was the question in regard to how do we bring more people into the community to provide more services? Was that the question? Nurses, doctors, et cetera? If that's
They just have a plan to do so.
Pardon me?
It's to retain the people and is there a plan to do so?
Well, see, the Rural Centric Care Organization is a business, and it can be owned by the district or an affiliate of the district. And it's a corporation with its own CEO and its own leadership. And it will be in the business of recruiting physicians. It will, because it has to have physicians locally in order to centralize care. When you have a $100 million medical budget, you have a lot of money and you have a lot of required services that can be supported locally. Telehealth is more of it's a nice thing to do. It's a very nice service to have, but I see it being important over the next couple of years, 2 to 3 years. But once the hospital opens and the clinic is in place with lots of doctors and relationships with existing providers in town like Intercare and the Loma Linda SAC and all the independent doctors and all the independent.
Yeah, okay, so for your questions, again, we're gonna, of course, if we selected, we're gonna take all the effort to even talk to all the staff in the hospital and keep them in-house. I think that's number one. Number two, of course, if they're not good with position, we can switch to a different one also. That's another thing we can do. Of course, we support local. That's why we talk about community again. Local first, of course, if we cannot do, even I'm going out to the community with a PCP, tell them to come in and help here. We can help here. That's why we're gonna talk to all the providers locally, invite them to help, invite them to work with us. That's the goal. But if you cannot get anybody here local, we do outside. We're gonna go to outside of the locality or somewhere else to bring it to here to help. We want every local. That's the key for the human resource.
By the way, the hospital will be valued at least $40 or $50 million once the Rural Centric Care Organization takes hold.
Okay.
$40 to $50 million.
Okay, next item, Ms. Hudson, I'm sorry, do you have any questions for any of the presenters?
They didn't have the mic back.
Okay.
Sorry, Ms. Hudson, can you say that again?
We're gonna put you.
I didn't have
I'm
anything.
gonna do the public and employees and people sitting there a favor and keep my mouth shut at this time and wait for the study session because I like to hear everything before I start commenting on it.
Okay, so next, item we have now, public comment. Is there any public comment?
I have a question. Oh, I don't have the right to speak.
Okay.
have every right. Just come to speak to the board, please. Okay. It's for the presenters, to all of them. I would like to know, how many, specialists are you
Madam President, for public comment.
Public comment, Ms. Herrera, it's, from public comment, it's, I'm not, they're not gonna you. Okay. On the split station. Is there any more public comment?
So the proposals on this agenda should not have been heard tonight. Hearing them violated civil and criminal laws. This isn't a matter of opinion. This is settled by statute and by case law. So first, I want to address the idea that the proposals were recently solicited, not solicited, or that they were solicited in a lawful manner. Staff violated government code when they invited coordinated proposals before any board authorization, which triggered the real property negotiations rule in government code section 54.956.8. That section requires the board to identify in open session the district negotiator, the property, the negotiating properties, and the purpose of the negotiations before any outreach takes place. None of that happened. By contacting proposers, providing materials, and arranging presentations, staff also created an illegal serial meeting under section 54.952.2. Since this facilitated pre-meeting negotiations outside public view, a pattern the court has condemned in Los Angeles Times versus Los Angeles. The agenda itself violates section 54.954.2 because the title hides that the board is receiving acquisition and control proposals. And holding this in a special meeting violates section 54.956, which bars non-urgent strategic matters like ownership and privatization from special meeting agendas. These defects make this hearing of these proposals unlawful. Public records that were requested by me also show that one of these proposals was solicited or discussed months prior to this bankruptcy filing. Its appearance here confirms that executive staff engaged in negotiations in violation of the Brown Act. The board clerk can confirm that I have sought records since October 4th for information related to Legacy Medical Group and any discussions to the sale, transfer, or lease of the hospital, including a meeting that took place this summer without proper authority. I submitted similar requests to the Riverside County LAFCO and Imperial County LAFCO for these same records on that same day. Now, the legal problem with these hearings is clear. Section 54.956.8 controls all real property negotiations. No disclosures have been made. Each proposal in this packet concerns use, control, or transfer of district property. Legacy MD seeks operational control. Ambassador Care seeks financial control and plan to replace the facility. Telehealth seeks management authority and transition rights. And Rural Medical Partners seeks OR access and expanded service lines. The law does not require a signed offer to trigger section 54.956.8. The act of hearing or evaluating proposals is treated as negotiations. This way, as you'll see, the rule is backed by case law in Shapiro versus San Diego, Southwest Regional Transit Authority versus Superior Court, and Bell versus the Vista Unified School District. Next, this violates section 54.956, the rule regarding special meetings. A special meeting can address only matters that occur before, that must occur before the next meeting.
Okay, any more public comment?
Anybody want to read the last 30 seconds of
Yeah.
Nothing here requires action within 24 hours. Shapiro holds that special meetings cannot be used for broad policy or future planning. Rescheduling due to an upcoming holiday does not allow conversion of a special meeting. Section 54.954.2 is also violated because the agenda hides that the board is hearing acquisition, privatization, and governance transfer concepts. Bell holds that hidden items void the action. For all these reasons, the board cannot hear these proposals. The only lawful action is to remove the item and stop this violation before it continues. I would also like to speak, thank you, Dr. Bo, Cardenas, anyone that showed up to come speak to the public. This community is plagued with lack of transparency, mistrust, division, all of those fun things. And this process started a year ago and is unraveled, and the things that I've seen and been made aware of are just mind-boggling. I'm pretty confident none of the board members were notified nor prepared for today's meeting with the agenda packets, nor did you study them or go through them, as you did not have time, nor did I, nor did anybody else in here. For Dr. Bo and Cardenas, they want the community's trust. However, we started off on a bad note. We started meeting back in August and we couldn't get confirmation from either this board or the CEOs. And we were being lied to. So we've started this relationship off with lack of transparency and mistrust, and that's unfortunate. We had a 10-minute break. We all went outside.
You had an opportunity to come introduce yourself and see what the public here has to say about this hospital and the community and what we want, and nobody did that. And then Cardenas and I YouTube show to go outside and have a conversation in the middle of the hearing. So there is the mistrust laid out right there in front of our eyes. We want a successful, productive hospital with a good culture of safety here. And a good environment. We want to be the best employer in life. That's what I think. Thank you for your time.
Any more public comment?
Yes, no, thank you for putting it out. Technically, I really don't know politics of this, that's why we violate, I'm sorry about that. Really, we did that on purpose to get anything more than just information, so we can present to the board. That's the key, the goal. And about this break, we went out, actually, we talked to the mayor, we talked to the city council. Of course, I can talk to you afterward. Again, we're not here to do anything bad or any bad intention. We're here to help the community. So I'm welcome. I mean, I'm here to talk. You know, my patient can come to my Facebook, even chat with me on Facebook Messenger all day. So it's not, I'm not untouchable. So that's the thing that I just want to lay out the community know. Yeah, we're here with a good intention. That's all. We did a wrong thing. We did make a mistake. We did. We apologize for that, and we did do wrong thing. It's not we are perfect. We're not a God. So again, if we do it wrong, tell us. Come talk to us. We will fix it.
Thank you for apologizing. That means a lot. Thank you. I think you're one of the first people in over here that's done.
Okay, and thank you. Is there any more public comment?
Good evening, Madam Chairwoman and board members and staff. On the staff report for this item, the presentations, why at the bottom of the first page, it says that the MSR from LAFCO identified several options for continued district operations, which included exploring a sale of the district's assets and partnering with third parties. So this is part of the staff report that you're referring back to LAFCO to do these things. And furthermore, it says these interested parties were notified of the opportunity to present their solutions and to the board for consideration. Informational packets were distributed to interested parties to assist in their proposals before presenting today. I thought we weren't negotiating. If you're sending out information that you won't even give the public in your community, what are you doing? You're negotiating. And I understand you're trying to resolve things, but you've gone behind the community's back with 4 entities from out of town. It's been ongoing for months. We've been asking about it. And now you've done this today. Is today a special meeting or a regular meeting? Because the regular meeting wasn't canceled that I was notified of. That started at 6 o'clock, right? Is that correct?
No, ma'am.
Okay, so when was it canceled?
We never scheduled a regular meeting.
You did it at the last meeting. It was agendized in your agenda of the last meeting that the next regular meeting would be tonight at 6 o'clock.
It was a meeting.
So that we're not having a regular meeting this month? That's a question, I guess. And we keep having special meetings. Just keep having special meetings. We're not having regular meetings, which gives 72 hours notice, which allows the board and all of the people in this community to have adequate time and resources to go through the agenda, ask questions, and be informed to make informed, educated decisions. That is not fair, what is happening here, especially to the board here. We got an email this afternoon updating this agenda with another PowerPoint and minutes. That's not fair either. I don't understand why there is just this huge disconnect and the lack of transparency. It's like everybody's got a secret and the community can't know. Just like the phone call on July 9th. Nobody can know. Thank you.
Thank you. Any more public comment?
Well, we have had, oh, sorry, my name's Dee Coates. We've had some interesting representations tonight on these different financial things. But bottom line is, where are they gonna get the money? Who's gonna pay this money back? They're gonna walk in here and invest $100 million? I don't think so. They're gonna want something back for it. I'm not sure Dr. Bell does. He's not gonna do it for free. He's gonna want an investment back. And we need to know all of these, where our money's gonna go. We have no money to play with at this point in time. It's all bound up in those chapter 9 that you guys filed. We can't even afford to pay that. And sometimes I gotta choose my words carefully. Sometimes I feel like you jump ahead without really thinking and checking things out. And I'm not saying that that makes you a bad person for doing that, but I'm also saying that at the position you hold, the community, you have to answer to them. I suggest that we table this and we have a meeting where it's already lined up the best project for each one. I just can't visualize all of these things. When you hear this thing that's too good to be true, it usually is. There's a catch to it. And I think it's time that this board sat and went over things properly, not in a day or an afternoon, especially when you've been working on it since July and you've not been forthcoming and letting us know what's going on. That's not fair to us as a community. This isn't a personality game. This is a life-saving measure for our hospital and our community. And the game's over. It's not a game anymore. It's getting down to choices. And the choices is if we have to close this hospital, who's going to be responsible for all the debts that shouldn't be possible because we didn't have those doors open? It's going to lay on your heads. And we're to the point now, you shouldn't have to be asked to resign. You should just automatically let somebody else try for a while because you failed and it's time somebody else. Let them fail until we get somebody that knows what they're doing. I appreciate what you've done, but it's not good enough. You got yourselves into this deep hole. You didn't even ask for help till there was no way to get to the top. Then all of a sudden you're wanting help. And you've blown money and nobody wants to give you any right now. And I can't blame them. So I say table it.
Any more public comment?
Yes, my name's Tara Bain, I'm a resident in Blythe, California, and I just went through needing our hospital personally very desperately. Sunday, I thought I had a heart attack. And I called Miss Dana to make sure she was on at the hospital. My husband drove me there, I was there, they wanted to admit me, but they can't. Okay, so then it was JFK going to the ambulance. There was 3 other people, there was people trying to be transferred out at that point in time. I looked at my husband and I looked at Dana, I said, can we give me some payments? Can I ALS transport myself? I was given a blood thinner in my stomach and I've been gone in Eisenhower until literally pulling up here. I pulled up here at this meeting and my husband said, you're not going to not go, are you? I said, no, I'm going to go. I said, I just spent 3 days in Eisenhower. I said, I've had CTs and MRIs and ultrasounds. They thought my appendix ruptured. I've got all kinds of doctor's appointments I have to follow up with my own personal health conditions now. I've left my children behind for 3 days. My job and this community. And all I wanted to do was be home. And it makes me understand why I've shown up for the last year. Why I think what everything that Elizabeth has done, everything Dana has done, and everything that Leslie has done, and Dee Coates, all the times we've stood up here and asked for some transparency, I got to live it. And there's a reason, and I believe in a God, and I know that God does things for a reason. And I did believe there's a real reason why this happened to me. I didn't get to roll up here. I've been listening to this live since Scirocco Summit, and I was like, let me just make it there. My husband said, you're nuts. He's all, it's cold. He's all, you're going to walk in there with your IV tag still on your arm, my bracelet from Eisenhower. We desperately need this hospital, and your community has lost all trust in you. And for those of you who are kind enough to walk away and step
aside and let somebody come in. It doesn't matter which one it is. We have questions. We want to know that we're picking the right person. That should be our choice and a board's choice that's going to make good choices for us. Because if I had had a heart attack, I would have been dead. It's not a joke. Okay, you're playing people's lives. I have kids to still raise, guys.
Any more public comment? Okay, seeing none.
Am I able to comment? Am I able to comment? Am I able to comment?
Okay, 2 minutes.
2 minutes? Okay, thank you.
2 minutes.
And I'm sorry for any trouble I may have caused. I'm sorry for any trouble I may have caused. First off, the Rural Centric Care Organization is owned by your group. Ambassador Care is paid a fee that comes out of the financing that creates the organization. So everything that we're proposing, but for a small retainer, is all based on performance. So we don't get anything, and it's only 1% of financing and so on. It's all in there in the proposal. Number two, the Rural Centric Care Organization, ladies and gentlemen, is the answer to your problems. It's your organization, and it transfers all that business that's leaving town right now that amounts to $100 million every year. It transfers that back gradually over the next 2 to 3 years. When you have that business plan adopted by the board of directors that's sitting right in front of you, that business plan then is presented to the financial world, and they say, oh my God, you're going to have a $100 million business operating in Blythe within 2 to 3 years. That is a big business opportunity. And as a matter of fact, it might be a $200 million company. And we will lend you money. We will invest. We will do this. We will do that. That's how it works. You have to have a strategic plan. I think Trina mentioned it. You have to have a strategic plan. And the strategic plan is to build your rural-centric organization, which then enables you to build a brand new hospital, which you absolutely have to do. No questions asked. You have to have both in order to centralize a $100 million business in Blythe, and it's totally doable. Thank you.
Any more public comment? Okay, seeing none, let's move on.
President Granita may be recognized.
Yes.
Okay. So your team, of consultants and staff have been working with the county, primarily through the county executive officer, Beth Van Wagenen, and others such as Supervisor President's office, RUA vets, etc., to find options to continue operations. These proposals have been forwarded to the county and will seek input from the county regarding the same. It is a consensus of this group that the doors need to stay open for your community and the as the mayor has referred to many times, if you close them, it's difficult to reopen. But the purpose of today is just to let you know there's options out there. There are people who are providing proposals regarding the same. So we're seeking direction from the board. Do you want to direct us to evaluate these numbers for viability to ensure continued hospital and clinic operations for later presentation to the board and the community? Would you like to direct staff to seek additional proposals for consideration and more broad search? Or direct staff as to if any of these options you want to evaluate as plan of investment. Staff is late, but the first two simply seeking direction. So do you want to direct us to vet these and to have them for presentation at a later time? And also do you want us to put out a more broad solicitation?
Well, there's more for solicitation. I think. You get more. Solicit for more proposals or hesitation. The proposal is presenting to us what they have to offer.
Why don't we do a formal RFP?
That's what that is. Get you ready some of them.
Just presentations.
Okay, let me restate this again. So these are the two that we believe you can do concurrently. Direct staff to evaluate these proposals to ensure continued viability and continue hospital clinic operations for later presentation to the board.
Yes.
And the other is to direct staff to seek additional proposals for consideration, and that would be, a formal RFP.
But then it depends on the time.
Right, but we don't know, I mean, that's unknown, so this would give your staff direction as to what to do now, and try to bring it back to you as soon as possible.
Well, if we have time for number 2. To solicit more, in a second, to solicit more proposals.
So the motion would be to direct staff to evaluate offers for viability to ensure continuous hospital and clinic operations for later presentation to the board, and direct staff to seek additional proposals.
I have a question. Is this on the agenda?
We can do the.
She had breakfast and no one changed the name.
So was there, is that how you want the motion to be, the first 2?
Mhm.
Okay. So, you may want to ask if there's a motion in a second.
So do we have a motion?
You need that?
Yes.
Did you make the second?
It's,
You did?
And Ms. Rowell, did Ms. Rowell move the motion?
yes.
I did. Carmelo, could you acknowledge the mayor, please?
Chief commented this was sent out to the county.
Yes.
When was it sent to the county?
Well, we've been in discussion with the county, but it was sent as the packet. But we told the county this is coming.
Yes, when did they get it? Packet like we have tonight?
They thought it would use it, the agenda. We haven't discussed it with them. We told them we're gonna be discussing.
Okay. They do, but they just probably got it today then.
Right, we haven't had our weekly discussion, but we were gonna discuss this.
Well, I'm just saying, we're reinforcing the discussion right now to let the county vent into this. And it's very important maybe to table this or to see if relating to this information, a lot of information to digest, and for the county and those people over there, respect that they're given to us to digest too. So in the motion somehow, it needs to be vented. The county needs to vent on this for the county stakeholders.
We second.
So there's a motion on the table.
Vice President Rowell? Director Sarden? You're muted, Director Sarden.
Oh, I apologize. Aye.
Director Brooks? Director Hudson? President Garnica?
Okay, next item on the agenda is.
Can we hear the motion again?
Yes, well, the motion.
The motion is in 2 bullet points of the process. Direct staff to evaluate offers for viability to ensure continued hospital and clinic operations for later presentation to the board. Direct staff to seek additional proposals for consideration.
So are we gonna do an RFP then?
Yes.
Okay, thank you.
Thank you, appreciate it. Thank you.
Next item on the agenda is a review and approval of minutes. Minutes from 27/2025, minutes from 9/22/2025, minutes from 10/1/2025. Do I have a motion to approve the minutes? That's second. Also question?
Vice President Rowell? Director Sarden?
Aye.
Director Brooks? Director Sarden?
Yes.
Sorry, Director Hudson? My fault.
We're at the 6:25 minutes. Why do we keep ignoring those?
I can go back and see, but I'm pretty sure they're complete, Ms. Hudson, but I will look into it and provide you with the response.
Yes.
President Garnica?
Aye. Okay, is there any public comment on any of the minutes?
Too late. You're muted.
No. Okay, let's move on. Item B, Medicare volume.
Madam Chairman, are we through?
Yes, and yes, you are. We're done with the presentation. We're moving down the agenda now. Thank you so much.
Thank you so much. And again, if I caused any problem, I really didn't mean to. Thank you so much.
Thank you.
All right.
Thank you. Thank you.
The district previously engaged Healthcare Reimbursement Solutions LLC to perform a volume decrease adjustment. This filing allows for a lump sum payment to hospitals that experience more than a 5% decrease in discharges, as long as the circumstances are outside the hospital's control. The COVID-19 global pandemic had adversely impacted almost every hospital, at least this much. This is a contingent fee engagement, whereas contractors only pay 15% of the collections if the funds are recovered through the VDA. So if it's determined that they're not able to collect, we don't meet the requirements, there's no fee. However, the VDA that had previously been approved for a prior fiscal year, which was fiscal year 2022, brought in an additional $70,866 in needed funds to the district. The company of which was previously engaged to perform these services assigned the agreement to former partners of the company to their new company, Reimbursement Recovery Partners. Staff recommends the approval of the addendum memorializing the district's consent of the assignment of the VDA to Reimbursement Recovery Partners LLC on a contingent fee basis to provide additional cash to the district.
Okay, is there any board questions or comments regarding this presentation? My board? Trina, any board comment regarding Mr. Rowe's presentation to the board?
Yeah, I have a question. So Michael, this is directed to you. So this would be for an assessment for.
So this would be, well, first, it's an assessment to see if the district would qualify for the volume decrease adjustment, which came from CMS post-COVID. So first, they would determine, is the district eligible? And then secondly, if the district is eligible, then they would work on the filing to be able, for the district to be able to collect on these funds if the requirement is met. There is no cash that goes out unless they are able to collect on these funds for the district, in that they assume that, or they assess that the district is eligible and they complete the filing that CMS would have to accept. So in the example for fiscal year 22, the $70,866 was received, and it was a couple month process between eligibility and working on the filing, gathering required information, filing, waiting for a response back. Then we received the money, and then we were invoiced. So since it's contingent fee, there's no risk up front. The funds would only, or the vendor would only be paid once the district received funds should be eligible. So this is supplemental funds that could help the district, and certainly helped a couple of weeks ago when we received this, about $70,000.
Okay, thank you for the explanation and clarification.
Ms. Hudson, do you have any questions to Michael's presentation?
No.
Any public comment on Mr. Rowe's? Okay, seeing none, close public comment. Is there a motion to approve? Is there a wait a minute.
Yes, is there a motion to?
Yeah,
approve
to
the
approve the
VDA agreement addendum?
I'll make a motion. I so move.
Thank you. Vice President Roma? Director Sardi?
Aye.
Director Brooks? Director Hudson?
No.
President Garnica?
Aye. Next item on the agenda. A motion to approve the Medicare volume decrease adjustment agreement Then the reimbursement recovery.
I'm sorry, it's item 7C, Omni reimbursement.
Oh,
Solution.
yeah. Standard services agreement.
Yes, and with this, I want to make sure Mr. Mang of Marshak Hazelwood is available. So thank you. So with this, the Omni Solutions was hired as part of the bankruptcy proceedings to act as a claims agent for the district. This is a necessary part of the bankruptcy proceedings. Omni has been able to notify creditors by the deadline of the bankruptcy and create a website with information for creditors. The recommendation is to ratify and approve the agreement with Omni Agent Solutions Incorporated. I will turn over to Mr. Mang of Marshak Hazelwood to provide the details as to Omni's role in the bankruptcy.
Hi, everyone. Can you hear me okay?
Yes. Yes.
Okay, great. Just so I've said my name, Mr. Rose did introduce me. I'm Tino Mang, the bankruptcy counsel to the healthcare district. On the presentation for Omni and to ratify their contract, the way I understand the prior authorization from the board is that there's a limited authorization to enter into contracts related to bankruptcy, but this has a dollar limit on it. For the initial work done by Omni Agent Solutions, as Mr. Rose mentioned, they were able to provide initial notice of the bankruptcy case, and they have created a website to start to publish documents. And the idea behind the agreement is that they will be allowed to take instructions from us as bankruptcy counsel to do any action that is necessary for noticing purposes, including potentially that we would need to notice all of the thousands of past patients of the healthcare district in case they had any claims. None are currently known, but notice needs to be provided to all of the creditors and parties in interest. This includes potential patients. And to protect the sensitive personal information of all those patients, Omni would serve basically as a gatekeeper for all of those claims to take them and to redact any personal information from them. In the course of our practice, we do see a lot of people file all sorts of sensitive personal information onto the court docket, and our suggestion is to use Omni as a way to mitigate this. Now, the problem is every time Omni does work, they have to send mail to 1,000 creditors. That costs money. It does add up to quite a bit. So pending ratification of their contract by the board to allow them to incur additional expenses, we have not asked Omni to do any further work. If the board ratifies the contract with Omni, then this will allow us to provide direction to Omni to incur additional expenses and to do more work. It will also allow them to start pulling documents and updating the website, so the website can be used as a bankruptcy noticing portal. And pending ratification, again, the Omni has stopped working and has not been requested to provide any services unless the board deems this to be a necessary expense. Now, I will also say that these services by Omni are only necessary in the context of the bankruptcy case being a continuing tool that the district considers important to use as a way to restructure and as a way to file a plan of adjustment. As soon as the district determines that the plan of adjustment and the bankruptcy case is no longer needed, Omni will not provide any further services and will not be requested to provide any more services. So it's completely flexible in that regard. I think, Mr. Rose, I'll turn it back over to you.
All right, thank you, Mr. Mang. One other item to mention is that if this is not ratified, then the responsibility does not turn back, or the responsibility does not dissolve. The district still has responsibility for notifications and protecting any protected information, which would include potentially patient information. That responsibility would then fall back to the staff. And I will say, you know, with the dedicated staff that we still have as the district, everybody is working at least 2 or 3 jobs internally to keep the doors open. So with this, we really value our staff. They're putting forth 110% effort every single day. So without the ratification of this, then the responsibility does not dissolve. It just goes back to staff who really don't have the capacity or necessarily the exact training and knowledge to execute this.
Okay, so is there any, board comment?
I have a question, Michael. What is the, you know, the
Hold on,
cost?
wait. Dr.
Okay.
Brooks speaking, hold on 1 moment.
Oh, I apologize.
Can you repeat that, Dr. Brooks?
He's asking a question regarding the defendant.
You have a question, Dr. Brooks?
We're on the question part.
You got it.
Question from Dr. Rose, Mr. Rose, presented right now.
I'm inclined to you know, having not had a chance to go through being a slow learner. And I think it's important enough, and I think the thing that the coach brought up, there may be some wisdom in having a chance for you to go through this. But my question to our president was, maybe the wives to the table.
So we turn this mic on for next time, please.
Okay, so, do you have any board comment?
Yeah, I just, if we take comment, Michael, what would be the result?
There you go.
Thanks.
Sorry, I was just asking Michael, what would be the consequences of tabling it as opposed to
I would ask Mr. Mang, right now, if we were to table this, let's say maybe for 2 to 3 weeks, is there anything that any court mandated filings that we need Omni for in the next few weeks if we were to table this?
There are no court mandated filings that we would need Omni for now. We do plan on filing a status report with the court, but that doesn't have to go out to everybody, I don't think. There is one item that may have to go out to everybody, which is if the district board approves I think it's on the agenda. But it may or may not be. So if the district board approves a request for financing, and I don't think it's on the agenda right now, but there have been discussions about trying to procure financing for the IGT. If a court motion is necessary to approve that, that will have to be put out on notice to the approximate 1,000 creditors. And just so you get a scope of like the cost of that, first class mail is what, 72 cents per piece now. You multiply that by 1,000, it's $700 already. And then you do have to pay for the manpower of someone putting that together. And each time there is a filing that has to go out on notice, then that cost is incurred. There are ways to mitigate this by filing a motion with the bankruptcy court to limit the amount of mail that we send out, but I can't file that motion until we actually have all of the patients get notice of this bankruptcy case too. So immediate consequence of tabling it, not a big deal. It's only when you want Omni to work that you should ratify their contract.
Okay, so, moving on, do we have a motion?
Why don't you finish picking the comments, public comment, and then it's opportunity for your motion at that time.
Okay, so
You already got all of theirs, so, if you want to ask Trina and, Ms. Hudson, public comment, see what their response is, and then the motion's clear.
Trina, do you have any, board comment regarding on,
Well,
treatment?
Actually, excuse me, the question I was going to ask was covered. Eventually, can we look at, can the attorneys look at making a motion to limit the mail filing on behalf of the district? That's going to get really expensive. How many, because that's going to be quite a bit of money that adds up over time if there's a lot that has to be sent out. There's still a lot of information that I'm not clear on actually with this.
Tina, did you want to address that?
Excuse me?
He's present. Okay, Trina, I believe there is an obligation under the bankruptcy law to send out these mailings. Okay. Tina, did you hear the question?
I'm here. Can you hear me?
Yes.
Oh, okay, so we can file that motion to limit the mailings at any time, but the motion is only necessary if there are filings that we need to mail out. So right now there are no filings that we have to mail out. So there are a couple of ways to handle this. You can table the ratification until the bankruptcy case becomes something that the district starts actively using, because right now it's not and there's no deadlines. The other thing is you can ratify and then we can use our discretion to not ask Omni to do things as well. Ratification simply gives you the flexibility.
Well, given our current financial situation, if there's no legal ramifications or compliance issues, you indicated that you had to know how many, be aware of the numbers of the patients and maybe get a motion to limit the mail filing. I don't know. I think personally that we should table it, the ratification, if it's not going to harm the district.
So just a clarification on the patients. We can't file a motion to limit the mail that we send to the patients unless they first have that first piece of mail that says, hey, by the way, you are a patient of this district and it's filed for bankruptcy. So we actually need to have that list of people get notice of the bankruptcy case first before we can file a motion with the court that says, please allow us to not send them any more mail. They at least have to get one piece.
Okay. Thanks for clarifying that. Thank you.
Sure.
Is there any public comment on this issue? Oh, Ms. Hudson, I'm sorry. Ms. Hudson, do you have any board comment? Okay, so is there any public comment on this?
Good evening, Madam Chair and board members. So I'm a little confused. The staff report calls for ratification and approval of this. It was signed and sealed a long time ago, first part of October. I believe you heard this same thing to ratify at a prior meeting. And now Mr. Rose is saying we are not ratifying. So can somebody explain what we are doing and what is being tabled? Because it's signed and there was a board meeting after the bankruptcy was filed and this firm had started working and it got ratified around the middle of October. So are we ratifying? Or are we not ratifying? And if so, what are we ratifying? Are we ratifying an amendment or the original contract?
So Ms. Anaya, as the CEO, has contracting authority up to $10,000.
Sure.
So that was the extent of what she signed.
Okay.
So to go beyond the 10,000 would be to ratify it. It sounds as though this board is going to opt to table that until later.
Have they been paid?
It's up to the $10,000.
Up to the $10,000. So they just need to be paid more. for additional services. Thank you.
We'll make a motion. Oh, I'm sorry, is there no public comment? Okay, so you will make a motion.
I shall move.
You table it? Are you gonna?
I second.
I think I have to make a motion first and have a second and then we vote on
Yeah.
it. Am I right?
Yeah. So, you wanna,
I can make the motion.
yeah, make the motion? All right, look at what you read, Tim?
Well, I'm just trying to,
Oh,
yeah, so.
okay, I need a motion to approve the Spanish service agreement.
No.
You want to table it?
I'm sorry.
Can
May I interrupt? Can I be?
Yes.
Okay. I understand that Dr. Brooks
Yes.
would like to make a motion to table this item. Is that correct? That's correct? Okay.
Well, I thought that it would come in two parts. The motion has to be made and seconded, and then we can, call for the question.
That's exactly right. So we have a motion to table. Is there a second?
I'll second, Lena.
Okay, call for the question.
Vice President Romwell, Director Sargent,
Aye.
Like I just asked one thing, are we doing it for the entire contents of seven A through,
It's only, we need that.
7C, this is only the on
only?
agent solutions.
Table.
That was an I, correct, Dr. Rowe?
Yeah.
Thank you. Director Hudson,
Yes.
President Garnica.
Aye. Okay, next item on the agenda is item D. A bridge loan.
So the hospital non-interest bearing bridge loan of $600,000 defaulted in December 2024. Some small payments from the 20% check write security have reduced the principal balance, I believe about $573,000. AB 104, which it passed in the summer, authorizes changes to the loan program. This leaves the district with options to make regarding this loan. Ms. Burke is here to present the options available and the impact that this will have on the district's finances.
Thank you, Michael. Good evening, President Garnica, members of the board, the community, and public officials that are attending online. Thank you, Michael, for the introduction. And again, I'd be remiss if I didn't also thank you and your team for all your help as we navigate all the complexities of the fiscal situation for the district. I know many late night hours have been spent trying to identify solutions for the district. What you have before you in this agenda item 7D in your packet is the CHAFA, California Health Facility Financing Authority, Bridge Loan 2 modification under AB 104, the Budget Act of 2025, and it's a first amendment to the loan. In June of 2022, the non-designated public hospital bridge loan was chartered into California Government Code. Loans were originally payable within 2 years at a 0% interest rate and are secured by the 20% of the borrower's Medi-Cal check write, or what we call reimbursement to the district for Medi-Cal claims. In December of 2022, that's when the district entered into its loan with CHAPA in order to receive that loan amount of $600,000. In December 2024, there's a correction to the staff report. It says 2025 that you defaulted next month. You actually defaulted in December of 2024 with the district's and we're going to correct that staff report, my fault, with the district's deteriorating fiscal condition and severe cash flow shortage. The district defaulted on that $600,000. It was a balloon payment that was due, and that loan currently remains in default. In June, with the help of Senator Padilla's office, Congressman Ruiz and Senator Schiff during the state budget process, AB 104 was passed, allowing participants in the loan program payment deferral until next month, December of 2025, when monthly payments would resume for 24 months under the amended loan agreement that you have in your packet. So what you have before you tonight are basically two options. The first option would be to execute the amended loan agreement that is included in your agenda package to approve that execution and authorize staff to do that. This would memorialize, should you choose this option, that you would be making and begin making payments on this loan. It would increase your budget shortfall that you already have of approximately $4.8 million by another $167,000 this fiscal year. We would need to provide for payment of $287,000 in year 2 and $119,000 in year 3. And that would be a total of $573,000 in the next 3 years. Under option 2, you would continue under the existing terms that you have, albeit in default, but that default is considered pre-petition debt and can be addressed during the bankruptcy proceedings. The security interest currently and upon default is the 20% medical check right, or the Medi-Cal check right payments that have been withheld and will continue to be withheld. The total withheld to date of your Medi-Cal payments is $26,730. Option 1 is anticipated to cost the district $573,000 in the next 3 years, with a budget shortfall of the $167,000 added for this year. And option 2 will cost approximately, we're estimating on the Medi-Cal check right, depending upon payments that come in, $83,000, with a potential that we can adjust that debt, this overall $600,000 during the bankruptcy case. Madam Clerk, can you please read the recommendation for the board? And then we'll take public comment and questions.
Yes.
Recommendation is a motion to approve or disapprove the execution of the First Amendment to the loan and security agreement and amendment and restate promissory note. Second recommendation is approve, if approved, authorize the chief executive officer or their designee to execute the necessary documents.
Vanessa, can you repeat on option 1, how much would it cost the district? You said 500, and can you give me
I have $573,000. That's the remaining balance on the $600,000 loan after taking into account the check rights that have already been withheld and offset to that.
Okay.
That's I rounded, but.
And Medicare's holding out 26,000.
No, Medi-Cal.
Medi-Cal.
It's all
Okay.
Medi-Cal. Yeah.
All right. And that was over what period of time?
Since December of 2024, under default, we've had to pay them, or they've withheld $26,730. So almost a year has gone by. We've paid $26,000.
Okay.
So maybe you recognize?
Yes.
Vanessa, can you tell this board which option is least expensive to the district?
Yeah, option 2 will cost approximately, we anticipate $83,000, given the current check right payment trend. The option 1 in the next 3 years will cost the district $573,000. So it is more expensive to execute the amendment than it is to stay in default through the bankruptcy case.
Okay.
And it stays as pre-petition debt. If you execute on these agreements, they will become post-petition obligations, and Tino can weigh in on this. They become post-petition obligations and would take a priority in terms of the overall bankruptcy case.
And if the agreement is executed, when is the first payment due, Vanessa?
The first payment
For
will be
option
due-
one.
For option one, the first payment will be due in about 2 weeks.
And how much is that first payment that will be due if the board elects option one?
Per the amortization schedule that I put in the packet, I believe it's about 26,000 a month.
Yes, and that's a monthly payment that the board would be obligated to pay out of its general fund if they select option one. Is that right?
That is correct. And I should mention too, on the available cash, currently it would take away from available operating cash reserves that we're using for payroll and other essential services. Yeah, the total payment, I estimated is 23,886.
So, Ms. President
And that's
Garnica,
and I should say that's monthly. So it's $24,000 a month.
so option one would be to approve the amendments and the associated documents, which would require you to begin paying back this loan December. Option two is to disapprove the first amendment, which would allow this debt to remain in bankruptcy and have it negotiated by your bankruptcy.
And what kind of impact will there continue to be on Medi-Cal? If any, will that continue that 20%?
That's what we estimated currently. Should the Medi-Cal payments start coming in at a faster rate on the AR than as currently being received, that amount can go up. So that's an estimate. It can never go higher than the amount you owe. But
And Chaffa's security interest is in 20% of the Medi-Cal check right. So that would be their remedy.
correct.
Okay, I see. Thank you for clarifying that.
So Vanessa, what is your recommendation then?
Obviously, while we're in bankruptcy, my first place that I'm going to go is to preserve cash to the extent possible to provide essential services. If $25,000 a month is something that you don't need for essential services, which I can't imagine right now to be the case, then you could initiate the loan. But I believe in its current fiscal condition, the hospital and the board should be focused on the essential services while we try to restructure the organization and get through the bankruptcy process and not create priority obligations above and beyond what we currently have.
I think the clarification is that option one or two?
Pardon? Can you repeat that question?
So you say option one, is that what you're recommending?
No, recommendation is option two.
Okay, that's
Yeah.
right.
Option two is to keep it in bankruptcy.
Thank you.
So again, option one is to approve that amendment. Option two is not to approve it and to let that debt remain in bankruptcy.
We want that.
What's the motion?
Dr. Brooks, for clarification, did you move to approve option two?
Yes.
Okay,
And take public comment.
you're right, sorry.
Yes. You want to back at the ranch. Are there any questions from the board? Well, we asked them. So is there any public comment?
Thank you, Madam Chair. I think that this item is a fine example of the reason this agenda and all of these documents should be out to your board within 72 hours in advance of your meeting. These finite issues do provoke a lot of questions, obviously. Since the board has not had time to even read the agenda by the questions being posed, why that would indicate that we've violated the ability for this board to make decisions just by simple fact that they did not get this agenda, which is very extensive, until late yesterday. So I would implore you to get back to your regularly scheduled regular meetings rather than special meetings where only 24 hours advance notice is given, and especially when you have such a heavy calendar with so many details, and give these board members an adequate amount of time to read through, have their questions, and maybe even reach out to the experts and have some of those questions vetted so that everybody has a better understanding. I think that's fair to the board. I think it's fair to the staff, and I think it's very fair to this community. Thank you.
If I may be recognized,
Yes.
this item and the ones that preceded it were in the last agenda, so all of these items have been provided to the board already. And they were tabled at that meeting, but you had an opportunity to see all of these items.
Any more public comment?
Okay, so my name's Tara Payne. So common sense here. You just made things in my brain even more complicated than they were before we were choosing 1 and 2, like Price is Right. So if they had this on their agenda previously, and we still don't understand it, what's the problem? It's been the same problem since I've been coming since last October. You don't understand your job. You don't know how to read. You don't know how to comprehend. You don't know how to admit when you fucked up.
Wow.
And that's why we're here. The pages are this thick. When you sit here as a community member and we can hear what's going on in the room and we know option 2 is the only way to go, and we gotta talk about it for another 10 minutes, it's insane. There's gotta be a definition of insanity here. I don't know how you sit there, on the board and make good decisions. I wouldn't even let you drive my car.
Any more public comment? Okay, seeing none. Why now, we need a.
Did we get board comment, Madam Chair? I don't recall.
You did.
Thank you.
Okay, well, the motion to approve.
Dr. Brooks moved it, and Rosie, did you second? Can we hear the motion, please? Yeah, the motion was to approve option 2. Thank you. Oh. It was moved by Dr. Brooks and second by Vice President Rowell.
Okay.
Can I call for the question? Vice President Rowell?
Aye.
Director Sardian?
Aye.
Director Brooks? Director Hudson disconnected the call at 7:36 p.m. President Garnica?
Aye. Next item on the agenda is IDT funding option. Rules.
The voluntary rate range program, IGT, is a major source of funds for the district. Board approved the district's participation in this year's VRRP IGT in July. Staff and consultants have been working with the Department of Healthcare Services given the district's financial condition. County and state officials are encouraged by the opportunity for the district to participate and do not want the hospital to miss the opportunity to participate, as the net proceeds would balance the budget, allowing the hospital allowing the hospital to continue to offer healthcare in Blythe and employ our dedicated staff. I will turn it over to Ms. Burke to discuss the options that have arisen in collaboration with our governmental representatives for the IGT.
Good evening. Thanks. This is agenda item 7E in your packet. On July 30th of 2025, the board authorized the district to enter into an agreement with DHCS and the health plans. The staff report in that agenda provides the details on the voluntary rate range program, which we had discussion on previously. So I'm not going to go over that in detail tonight. What is most important is previously discussed with the board during the fiscal year 25-26 operating budget presentations is that this program provides nearly 9.9 million in funding for this fiscal year, and that to participate in this funding, we must make the contributions to DHCS, Department of Healthcare Services, by this Friday. That amount of contribution is approximately $3.5 million, as you can see on page 1 of the staff report. Since July, and the approval was given to staff, the legal team, and financial consultants have evaluated as many options as possible to fund the IGT programs. Letters have been sent and meetings held at all levels of government with Senator Schiff and Padilla, Congressman Ruiz, Governor Newsom's office, and healthcare policy advisors in DC. In addition, we've contacted several financial institutions to help secure bridge financing and funding, term loans, and other options. What we know is that the state and county officials don't want the hospital to miss the opportunity to participate in this program. They understand the significance of this issue, and they want to keep the hospital open. They want to keep the people employed there in Blythe and providing the needed patient care. This whole team has been working on behalf of the hospital to request an extension from Department of Healthcare Services from this Friday until the end of December to make the $3.5 million contribution. At this time, we've asked the state to provide a legal review to see if it can provide the funding. And we understand that the county, if they decide they can assist the district financially, would require certain conditions to be met. The district does not have those conditions or know if they would be forthcoming at this time. What I can tell you is that I stepped away from this meeting earlier today, just a little bit ago, and had a conversation at 7:30 at night with the Department of Healthcare Services director. She's very aware of the issue, and their legal team is working steadfast to try to come up with a resolution on the extension and ensure that the state can offer that extension to the district. I mentioned to her that it was critical that we have the extension so that we can try to meet the funding requirements. As mentioned in the staff report, legislative officials have said that they're out of session right now, and the legislature won't reconvene until January. And if they were to be able to come up with funding, and if the state was to be able to come up with funding, it would require legislation and an appropriation. And so that I do know as a recent development as of just the last half an hour. So with that, I'm going to ask the board's clerk to read the recommendation on this status report, and we'll go from there.
Thank you, Vanessa.
The recommendation is to receive and to file the report.
In addition, okay, if I can add. So in this line item, it says to receive and file, and then there's a blank. Now, these motions are a convenience, they're not a requirement to set them out in the agenda under the Brown Act, under Robert's rules, under Rosenberg's rules. So this allows you to craft your own motion as it may be. So what you can consider is to allow staff to continue to pursue IGT funding, whether it be from the state, the county, or from a private source, to be brought back to you. And as Vanessa said, we've been in contact with the county weekly. They understand this and actually said, if you can find the IGT funds, we want the hospital to remain open. We want your employees to remain employed. do what you can do. So these three offices are there. Adam Schiff's office has been calling frequently. We're in close contact with them. They are too trying to secure funds. And the county, of course, is very supportive. So all of these agencies are well aware that this is before you. They've encouraged us to tell you to seek the IGT funding. Whatever happens with the hospital, however the district is formed, whatever everyone decides, that will come. But they just don't want to see these doors closed. And this is your opportunity.
Okay, so is there a motion to allow the staff to pursue the IGT plan?
Hold on. You're getting questions and comments from your board and then the public. I'm sorry.
Okay. So this, do you have any board comment, Tina, regarding the allow the staff to pursue the AGT funds? Me saltes la.
Sorry.
Okay, so is there any public comment?
Good evening, Madam Chair, Leslie Jessup Watkins. So in the staff report, looks to be page, sorry. Yes, at the top of page 3, why under county funding, it clearly states that the county has expressed interest in helping, but is unwilling to provide this large amount of funding due to concerns over the district governance and fiscal management of the funds. And I think that it's been very apparent over the last, well, since January anyway, that there are many factions that feel the same way, that we would love to help. And there are many people in this community and many groups that have large sums of money in this community that would be gladly helping if it were not for what is exactly called here, the district governance and the fiscal management of the funds. It's honestly a no-brainer. People would give if we knew that the money was going to be used correctly. And the lack of trust has provoked this inability for anyone to give. I myself personally would give a lot of money. I know a couple of groups in town that this funding is exactly, that we have money that this would qualify for, but not with this current board and administration. And I think your fourth option down on the bottom, to obtain high cost financing, I didn't do the calculation on it, but to have a $450,000 interest payment on a $3.5 million loan, it doesn't specify the term on that or anything, but that's pretty high. That's really high. And I don't know that we have the money for that. So I'm hopeful that what Ms. Burke is saying is correct, that, you know, there's some hope there, but we've repeatedly heard from LAFCO, from the county, from the city, from the mayor, from citizens, that until there are corrections made to who sits on this board and the administration, that money is not going to come forth. And yes, we are at this crossroads with regard to this IGT. And you had some proposals here tonight that offered, amazingly, they offered a $3.5 million buy-in. Isn't that amazing that that's the amount that they would come up with in just a few weeks? It's amazing that it's that amount that they would give us. It just so happens. So be careful and please make a great decision. Thank you.
Any more public comment? Okay, seeing none. So none. I make the motion
Make the motion to receive it.
to allow the staff to pursue IGT funds.
You can ask for a second. If there's not a second, then you can move on, but you can.
I'll make a second. I'll second.
Any clarify the motion.
To allow the staff to, pursue the IGT funds.
That wasn't the motion. However, before you, there's two motions. I mean, there's two motions you can consider. You have a motion on the floor, but I'll tell you what the other one is. Then we have to take, if there's another motion, then you take the second motion first. But let me just tell you. The first motion is to receive and file.
Yes.
The second motion or opportunity would be to pursue the IGT from state, county, or private sources.
Is it our one?
No.
You make a recommendation on that, but, my interpretation of it is to receive and file. And then maybe table until.
Not that.
No, that is part of it.
With respect to the IGT, there is not time to table, so you need to make a decision. Under parliamentary rules, if you have a motion, there can be another motion made. The second motion is the one that goes first, okay, when you do your voting. So in this regards, you have the opportunity to receive and file this report or to take action and to direct staff to pursue the IGT from the state, the county,
Yes.
or private sources.
Yes.
Okay, so those two opportunities. So whatever you want, if you want to move forward with a receive and file, that would be it. Or if you want to have the other motion, a second motion to direct staff to pursue IGT funds, you could do that. Is he allowed to think for himself, or do you do that for him too?
Well, that'd be the motion.
No. You had a second.
So that's the motion, yeah, so there could be a second motion, if you want to have a second motion. And then take the second motion first, that's the way parliamentary rules are.
For the question to allow the staff to pursue the IGT funds and, for the,
So you're making a second motion to do that? Okay, there is the second for that motion.
I'll second it.
So there's two motions on the floor. You take the second motion first.
Yes.
Vice President Roel. Director Sarden,
Aye.
Director Brooks,
Aye.
Director Hudson is absent, President Garnica.
Aye. Okay, next item F. LAFCO sphere of influence and written response, Michael.
So LAFCO will be holding a public hearing on December 4th to consider the district's sphere of influence. The CEO of LAFCO has allowed the district additional time to prepare written comments for submission given the date of this special meeting. I will turn over to Ms. Wade to provide additional details on the recommendations for written comments to LAFCO from the district to be presented at the public hearing.
So as you know, LAFCO has scheduled a public hearing for December 4th to consider an amendment to the sphere of influence. The written comments are due by November 20th. We reached out on behalf of this board because we knew that we'd only be able to speak with you the day prior to written comments for an extension of time. The chief executive of LAFCO responded, did provide an extension of time through November 24th. And he stated that this is an administrative item. Only if down the road the district does have to be dissolved. This does not alter anything operationally or otherwise that the district is currently engaged in. So again, your team is working very closely with the county regarding moving forward. And so they will make that decision at a later time. But we want to get, or we're seeking direction or approval to allow your staff to provide written comments regarding the need for healthcare services within the district's boundaries. And also with respect to plan of adjustment, which would require bankruptcy approval about how you'll go forward, how the plan is for you to be financially viable in a sustainable hospital, and provide necessary and quality care to your community and also to continue employment of your employees. So again, this is to seek authorization to allow staff to submit written comments.
Okay, so is there a motion to approve item F?
Second.
Any call for the question? Oh, I'm sorry. Is it good comment? Tina, do you have any board comment on the LAFCO sphere of influence written response?
I'm having, I'm trying to resolve a IT issue. I'm on the phone with IT. I'm having some problems, so I didn't hear everything, so I'm going to abstain.
Oh, we don't have a vote yet. This is just, if you had any
Okay.
board comment.
Yeah, just give me a second. Thank you.
Okay, so we'll go on to public comment.
Good evening, Madam Chair, Leslie Jessica Watkins. So what is the impact with changing or obliterating the sphere of influence?
Pursuant to what the LAFCO stated, nothing happens operationally. You continue to operate. It's a placeholder. They're not going to do anything further at this time.
But what is it?
It's a zero sphere, meaning you have zero sphere of influence within.
Okay, so what does that mean though? What does that truly mean? Does anybody in this room know what that means?
This is public comment.
That means you're all the same.
Right.
Leslie, can you?
So the district, can we put the map up from the agenda? No? Okay. So the district actually goes out just west of, probably out to Wiley's Well, north to, and I've said this before, north to the San Bernardino County line, south to the Imperial County line, and west to the river. That is the actual district boundaries. The sphere of influence goes almost out to Shreko Summit, west of Desert Center, several miles. That's where the sphere of influence is. And so the question is, if LAFCO is going to take away our sphere of influence, what impact does that have with all of that acreage that we're going to lose as far as our sphere of influence for later? And with regard to potentially increasing our district boundaries later? That's the question. You're all worried about this letter that we need our hospital and all that, but that's not what they're hearing on, at their next meeting. They're talking about a sphere of influence, which means the area that we serve. So I think that somebody needs to do some homework on what the impacts are going to be if they eradicate that sphere of influence. Thank you.
Any more public comment?
Yes, it's George Cooney. Been talking to LAFCO, and I got the notification this was coming down. Talked to the director, and basically he explained this is a state thing since you filed the bankruptcy, that this is part of this dissolving the district. So what they're doing is putting this in place, so when this comes down, this district disappears. How this comes out of bankruptcy. So you need to look at it very, very hard. So they're already looking at, if something comes down, this district is dissolved.
Thank you, Mayor.
Thank you, Jordan. Any more public comment?
Michael, do you have any recommendations?
I'm a slow walker at this point. My name is Dee Coates, and I guess if they're gonna cut our sphere of influence, and they're going to prepare us to get less and less. And you guys didn't even know about it. You didn't even know what this item was reflecting. Why didn't you investigate it and ask? You got an attorney here that seems to know everything, but she didn't even know that? You're paying her pretty good money to not know things that are very important to be known. And you sit here and you're willing to pop this stuff through and not even understand what you're voting on. And that's really sad. You talk about us coming together and holding this community so we can have a hospital. What part are you playing in keeping it together? At this point, I can see you don't even know your homework. You don't study this stuff. You know, I was up last night till midnight reading this stuff. And you guys don't. There's something wrong with that picture. And you really need to sit back and think about what you're voting on. Not just pushing stuff through. There's not a dollar amount on everything. That's all you guys care about right now is how much money you can get. But you better find out what you need in the process. Think about it.
Any more public comment? Public comment is now closed.
If I may be recognized,
Yes.
with respect to an amendment to a sphere of influence, what they look at is whether or not those services are still required in the district, whether financially viable, those things that were listed in the staff report. So that is why those items are going to be addressed. And it is intended that those items also be addressed in the plan of adjustment that's going to be submitted after your approval to the bankruptcy court.
Okay, so do you have a motion?
Second.
Okay, call for the question?
Vice President Rowell? Director Sardian?
Hang on.
Director Brooks?
I'd like to table this one till I have a chance to read it.
Right now, we're going to question for the motion. You moved the motion? Dr. Brooks, you approved?
Not a second one.
Ms. Rowell, second.
You want to do a second motion?
Already set outside, he doesn't have.
Okay. We can do this. So you have until Monday to submit written responses to LAFCO with respect to this proposed amendment. There's a motion on the floor to allow that. You can make a second motion if you would like to table. And if you make that second motion and it's seconded, then that would be voted on first.
What should I do?
You do whatever you think is in the best interest of the community. So if you want to have your staff submit written comments to LAFCO by Monday, then that's the motion. If you want to table it, then that's also a motion.
Okay, table, so at least I have a chance to read it.
Okay, so if there's a second,
So I secondly second them.
you made the motion, so you would need a second to table it. And if there isn't a second, then it dies and the first motion is considered.
I know.
You already said what you had to say. Who needs a second motion though?
If someone wants to second it, they can. They don't have to, they can. If there's no second, that motion dies and the other motion is considered. If there is a second motion, then that has to be taken first.
Okay, so, The motion was item F to approve the NAPCO scale of influence and written response by Monday. So you-
That was the first motion, correct? And the second motion.
So I don't, did you, either of you second that one?
I'll second it.
You're gonna second his motion for the second?
Yeah, her motion.
Okay,
The motion for the NAPCO scale of influence and written response.
so Dr. Brooks' motion dies for failure of the second, is that correct?
Yeah.
So then that first motion, who made the motion, who seconded?
Motion was moved by Brooks and seconded by Rowell to approve.
Okay.
And that's where I was taking, I have a question.
Yeah.
That makes sense.
So now you look.
I'm gonna call the question again. Vice President Rowell. Director Sargent.
Looks like he's.
You're muted, Director Sargent.
She hasn't been there in a long time.
Aye. Aye.
Director Brooks. President, Director Hudson's absent. President Garnica. Thank you.
Next item on the agenda is item G, the warrant notice renewal. Michael.
This is the item our staff members are probably most concerned about if they're watching on the live feed. Employees were issued a warn notice in September notifying of the potential for layoffs and actually the very high risk of layoffs. Statutory obligation gave employees 60 days notice, given the options available to the district, the IGT, and the continued work to collect on outstanding AR balances. The board now has the option to extend the warn notice period for another 60 days. And with this, I will just comment in speaking with all of our employees, both Ms. Anaya and I meet with employees weekly to provide updates. I will say everyone is very concerned about this, and rightfully so, as this is their jobs. I will say that our staff provides so much, they understand what's at stake. And a lot of the staff who have left have stayed on as per diem employees without they necessarily fully remove themselves from the hospital, but they recognize just how important this is, and I want to make sure that's stated. It's just how hard our employees are working and how much they care about this. I'll turn over to Ms. Wade to give the details of the warn notice.
Yes, so there's a statutory obligation to provide notice to employees for the potential for layoffs, which is only fair, right? Your employees are entitled to notice they may lose their job. And given the fact that there was 5 days of cash on hand, thought it was prudent to do so. So now that day is coming, still working towards collections, still finding them coming in, and we have this opportunity for the IGT. So we are requesting or recommending that you renew the warn notice for another 60-day period that provides some certainty, hopefully, to the employees and the community that you're going to continue to move forward. Hopefully, we can rescind it at some point, but it's really day to day at this point with the number of the amount of cash you have on hand.
Okay, so is there a motion to approve the warrant notice renewal?
Would you like public comment?
Yes. So that, yes. Public comment.
Madam Chair, your staff report indicates that warrant notice extensions, I can't see it here, but are only available for 30-day extensions, not 60 days as indicated. Thank you.
There was an updated staff report that was provided to you contemporaneously with making it available to the public. So it's 60 days. Yesterday? That was after yesterday, it's supposed to be done.
Any more public comment? Okay, no more public comment, so we need a motion to approve the warrant notice renewal. Okay, Alder Person.
Vice President Rowell. Director Sargent.
I'm going to abstain since it's an employee issue.
Director Brooks. Dr. Hudson is absent. President Garnica.
Aye. Okay, we will now move into closed session. Public comment regarding closed session. Closed session agenda item. Medical staff credentialing and peer review pursuant to health and safety code. Section 32-155 and government code section 54-957. Practitioner 5058, practitioner 5666, practitioner 57. Practitioner 57, practitioner 31-5-150. We'll now return to open session. And who wants to report?
You would like to report on President Garnica? Okay. With respect to item 1A, B, C, and D, those initial appointments were approved unanimously by all of the board members in attendance. That would be Carmela Garnica, Dr. David Brooks, Director Rosie Rowell, and Director Tina Sarton. With respect to practitioner number 315150 reappointment, this practitioner was approved for the emergency department unanimously. There was no action taken with respect to surgery, as there is no surgery offered at the hospital at this time. With respect to item 2, discussion with council regarding the Chapter 9 bankruptcy, there's no reportable action.
This meeting is now adjourned at 9:30.